अरे अभी कोई एक मैसेज आ रही भाई,
मैम उसको गॉट इट कर दीजिए।
गॉट इट कर दे।
जी मैम।
ओके।
But Sandeep ji, people are saying कि they are not able to join through that link.
मैडम अभी स्ट्रीमिंग हो रही है ना?
हाँ
अभी स्टार्ट हो रहा है।
अच्छा।
He's just connecting. वो चेतन है, वो ये ग्रुप में भी अटैच्ड है। ये देखिए आप, you can see netcast चेतन. He's just mixing both the groups. It will get started streaming.
हाँ जी, अच्छा, आप खाली होके ज्वाइन कर लीजिएगा। हाँ जी प्लीज। हाँ जी, ठीक 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 ठीक।
बहुत सही, गायनी पढ़ा रही है
अनुराधा जी। ओके।
रंजना गायनी पढ़ाती है।
नहीं नहीं, वो अनुराधा जी का फोन था। डॉक्टर अनुराधा खन्ना जस्ट hung up. She's saying that she's getting some tests done. She'll join later. She's saying you please give my best wishes and start the. I'll join later. So when she joins, then you can welcome her, Ritu. ठीक है?
Yeah, Chetan, can we start?
Yes, sir. We are
starting. Okay.
Okay, madam.
Good afternoon, ma'am. I myself, Sandeep, of Creative Division of Akumentis Healthcare Limited, along with Mr. Rajesh Gurani, who is our Executive Senior Vice President, Mrs. Rashmi Tiwari, who is based at Mumbai, Mrs. Shweta, who is based at Mumbai, Mr. Prashant Srivastav, who is based at Prayagraj as Zonal Business Manager, working as specifically, and Mr. Manish Verma, who is based as Area Business Manager, taking care of Prayagraj and Varanasi operation, Mr. Sandeep Pandey, Mr. Atul Upadhyay, Mr. Shravan Kumar, and Mr. Nitesh Srivastav. Collaboratively, we have welcome the delegates of Allahabad Obstetricians and Gynecology Society and also Varanasi Obstetricians and Gynecology Society. And live webinar of fetal growth restriction. Without taking much of your time, now I would like to introduce Dr. Ritu ma'am. Without her, this webinar wouldn't have been possible. Now I would like to introduce Dr. Ritu Sinha ma'am. Dr. Ritu Sinha is right now Secretary of Allahabad Obstetric and Gynecology Society. She is senior consultant at Dwarka Hospital, Prayagraj. She is trained in gynecological endoscopy at AIIMS, Delhi. She is trained in colposcopy and preventive oncology at SMC. She is ex-treasurer of AOGS 2017. She has published an article in an international journal of clinical obstetrics and gynecology, and presently she is faculty at various national and state level conferences. Also, she earns special interest in high-risk pregnancy and adolescent health. Now, I would like to invite Dr. Ritu ma'am to please initiate the formal proceedings of this session. Thank you so much.
Thank you, Rajesh ji. Let's begin now. Good evening and a very warm welcome to all the esteemed faculties we have on board and all the guest delegates who have joined in. Today, it's an honor for us that Varanasi Society has collaborated with our AOGS in bringing out this virtual academic feast. So, first of all, I request all the esteemed members to join us and start the session with a short prayer. Dear God, I need you more than ever. Please bring peace to my confusion, joy to my sadness, and hope to my heart. Amen. May God bless us and help us in difficult times. Now, let us begin our scientific session on fetal growth restriction. We all are aware of the fact that the evaluation of fetal growth is one of the key objectives of prenatal care, and it is the second leading cause of perinatal mortality after prematurity, affecting approximately 10 to 15% of pregnancies, with 5 to 10 times higher risk of intrauterine death. So today we shall be discussing about the various aspects of impaired fetal growth, starting from etiopathogenesis to the prevention, and to the most important, the role of Doppler in managing fetal growth restriction. To throw the light on each aspect of this fetal growth restriction, we have three eminent speakers among us: Dr. Lalita Shukla Madam, Dr. Divya Agarwal, Dr. Anupama Ravi Futela. All three of them are presidents of their respective societies, Allahabad Society, Varanasi Society, Rudrapur Society respectively. Also, we are very delighted and privileged to have stalwarts Dr. Anuradha Khanna Madam as our chief guest, Dr. Ranjana Khanna Madam as our guest of honor, and chairpersons Dr. Manju Verma Madam, Dr. Andaleep Agarwal Madam, Dr. Madhvi Mittal Madam, Dr. Mamta, and my dear friends, Dr. Amita and Dr. Pushpa Pal. We welcome you all. Now to begin with, I would like to invite and welcome Dr. Lalita Shukla Madam for her presidential address. Dr. Lalita Madam, over to you, please. Dr. Lalita Madam.
Hello and good evening.
Dr. Lalita Di, please come.
आवाज आ रही कि नहीं?
हाँ.
Good evening, respected Manju Verma ma'am, all seniors and friends. It is a very good occasion to invite all of you for a topic which is a difficult thing for all of us. FGR concerns the patient, her relatives, as well as the obstetrician. So welcome everybody, Dr. Verma ma'am, all the delegates, all the people attending this meeting. And I hope you enjoy this session.
Thank you, Dr. Lalita Madam. Now it gives me immense. Please remove this. Didi, आपका वो आ गया है.
वो हाँ आ गया है.
Didi, please stop sharing this.
Okay.
Thank you, Dr. Lalita Madam. And now it gives me immense pleasure to welcome and introduce actually our chief guest, Dr. Anuradha Khanna Madam. She is not able to join right now. She might join later on. So I'll welcome my our guest of honor for today's session. Please, Sandeep ji, please display Dr. Ranjana Khanna's CV. Dr. Ranjana Khanna Madam ki CV please display. Yes. Now I welcome our guest of honor, Dr. Ranjana Khanna Madam, a very dynamic, foxy and
Ritu, Dr. Anuradha Khanna has joined.
Okay. Welcome, Madam. Namaskar, Madam.
She has just joined.
Yeah. Please. Namaskar, Madam.
Namaste.
Okay, now we'll begin it again.
Actually, I was somewhere else. So I said, Ranjana, you continue with you. I will join.
आपका फोन नहीं चाह रहा था.
हाँ नहीं अब आप start करिए. You are the chief guest. Chalo Ritu start.
Ji ma'am. It gives me immense pleasure to welcome and introduce our chief guest, none other than Dr. Anuradha Khanna Madam, a very dynamic and motherly figure for all the gynecologists. I must say, not only in UP, but across India. Madam has been the head of the Department of Obstetrics and Gynecology, Banaras Hindu University, past president, VOGS. She is the president of SFM UP chapter, president Varanasi Menopause Society, and president-elect of UP chapter for the year 22-23. She has been organizing secretary of AICOG in 2012 and chairperson for UPCOG in 2019. Madam has many awards on her credit. She is fellow of Academy of Medical Sciences, fellow of WHO Fellowship Awardee, UCC Fellowship Awardee, Indo-Hungarian Fellowship Awardee, Indo-Netherlands Fellowship Awardee, and she has also received Best Paper Award in AICOG 2010. She had more than 120 publications in national and international journals on her credit, and she has written many chapters in several books. She has guided 42 MD theses and 4 PhD theses. Madam, you truly are an inspiration for us, and you are such a humble person. We welcome you, ma'am, and request a few words of blessings from you. Over to you, ma'am. Ma'am, please welcome. Please say a few words.
Very much. Thank you very much for invitation. And it's an extreme pleasure of mine to join this meeting as a chief guest, along with Dr. Ranjana Khanna, Dr. Shukla, Dr. Divya, and all the secretaries of both the society. And I'm not at home, but I'm somewhere else. So I'm joining from there. And it is my extreme pleasure. And the subject you have chosen today regarding the fetal growth restriction, that is a very, very important topic for us. And if we see the etiopathogenesis, which we are going to discuss, the management we are going to discuss, we will find that they are very much overlapping. Only you cannot stick to one type of etiopathogenesis. You see, they are overlapping, like you are getting preeclampsia, you are getting genetic disorders, immunological disorders, infections. So once you see a patient, you have to open your vision with history examination and investigations so that you will not miss any of them. Sometimes in one pathological fetal growth restriction, you will get many more things to be investigated. So one should have a very great vision, and I'm very keen to listen all the speakers and the chairpersons, their comments. And you are a very good moderator, dear. You are moderating it very well. And my heartiest congratulations to both the presidents and secretaries of the Society of Allahabad and Varanasi. And I'm extremely obliged. Kindly go ahead with all my best wishes.
Thank you so much, madam, for blessing us. And now I welcome our guest of honor, Dr. Ranjana Khanna, madam, a very dynamic Foxy enthusiast. Though we all know her very well, but it is my privilege to introduce her. Madam was the National Vice President Foxy in 2017. She is the founder President Prayagraj chapter of ISOPA for the year 21-23, ICOG Governing Council member for the year 21 to 23. She is the president. She was the president of Allahabad Society in 2013 to 2016. She has been honorary secretary, treasurer, and she has been organizing chairperson at various national conferences at in Triology of Delhi in 2017. Madam has also been organizing secretary in National Conference SAVMA, which was held at Allahabad in 2016. She is faculty at various national and international conferences and webinars. Madam has received many awards like Smriti Milan Award in AICOG 2000. In 2013, Foxy DK Tank Reproductive Healthcare Promotional Trophy in 2015. Madam has been felicitated at Safe Motherhood Committee at AICOG 2014, Public Awareness Committee and Family Welfare Committee at AICOG 2016, Oncology and Midlife Management Committee at in 2018, and Public Awareness Adolescent and Breast Committee. Madam, you truly are an inspiration for all of us, and we request a few words of blessings from you too. Over to you, ma'am.
Thank you so much. At the outset, I really feel blessed and honored to be invited by my own society, Allahabad OB-GYN Society, as the guest of honor. For that, I would like to express my gratitude and thanks to Dr. Lalita Shukla, the president, and Dr. Ritu Sinha, the secretary of AOGS. See, it's such a pleasure to be with my society, AOGS. The blessings of the seniors and the love of all my colleagues and my friends and my juniors. I express all that I have achieved in Foxy. I feel that all of you are part of it, because after I was the president of AOGS, I moved on to become the vice president of Foxy. And now with everybody's love, I am going to be installed as an ICOG Governing Council member on the 3rd of July. So I would really feel very happy if all of you are there to be with me, to bless me virtually, of course. And I really feel great in sharing the dais with stalwarts of UP like Dr. Anuradha Khanna ji, who is an excellent academician. And besides that, she is a very good friend of mine. And of course, Dr. Manju Verma Didi, she is an excellent academician, and both Dr. Anuradha and Dr. Manju Verma, they are renowned people of not only UPCOG, but also they have their own stand in Foxy. So it is my pleasure to share the dais with them. And we have lovely speakers today, the presidents of 3 societies, Lalita of AOGS, and then we have Divya from Varanasi and Dr. Anupama from Rudrapur societies, and lovely chairpersons too. Dr. Andalib is there, Dr. Amita is there. And what to talk about Manju Didi, I have already said that it feels great to be there. And with her, Dr. Mamta is there, Pushpa, Madhvi, and it feels really good. As I said, Ritu, you have chosen a very nice topic. FGR is indeed a very important topic nowadays, and we are seeing so many cases basically because the incidence of FGR has gone up. The age of marriage of girls has increased, and because of that, all these girls, everybody has become a professional, and because of that, there's so much stress in our lives, and because of the stress, there's early onset of hypertension, diabetes, and all these conditions are just, and as Dr. Anuradha Khanna said, we can't just separate one from the other. Everything is sort of mixed and overlapping, and detailed history and all is very important. And now, of course, the nitty-gritty and the details of the topics are going to be discussed by our very, very nice speakers, and looking forward to hearing the talks. Thank you all so much, my very, very dear Allahabad Society, and a very warm welcome to Varanasi Society, which almost feels like our own society. Thank you all so much. Thank you, Ritu, for the invite.
Thank you, Ranjana ma'am, for blessing us, and we are honored to have you with us today. Now we quickly move on to our first session of today's webinar. Sandeep ji. For today's webinar, that is etiopathogenesis of fetal growth restriction. And the speaker is Dr. Lalita Shukla madam. To chair the session, we have Dr. Andalip Agarwal with us and Dr. Mamta Singh. Dr. Andalip Agarwal madam is very polite and a kind-hearted person. We all know her as a senior consultant gynecologist and infertility expert. And she has been president of Allahabad Society in 2017 and 18. She is the member of Foxy, member of Indian Medical Association, Indian Fertility Association, Indian Society of Assisted Reproduction, and she has special interest in high-risk pregnancy and infertility. We welcome you, madam. Now I invite Dr. Mamta Singh. Sandeep ji, please put the CV of Dr. Mamta Singh. Sandeep ji, please put the CV of Mamta Singh ji. Dr. Mamta Singh. Yes, now we can see it. Now I invite Dr. Mamta Singh, another co-chairperson for this session, a very pretty and cheerful person. She is the Associate Professor in the Department of Obstetrics and Gynecology, IMS BHU. Presently, she is Secretary of Vox for the year 21-22. She has worked also as a Treasurer in Vox, Joint Secretary in 2019 and 20. She is the Scientific Secretary for the year 2021. She has presented many papers in national and international conferences. total 15 publications, and she also has special interest in high-risk pregnancy. We welcome you both, Dr. Andaleep Madam and Dr. Mamta Singh. And now I request Dr. Mamta Singh to kindly introduce our speaker, Dr. Lalita Shukla Madam. Dr. Mamta Singh?
Yes, thank you, ma'am. Thank you, Ritu ma'am, for kind words. And first of all, a very warm good evening to everyone. And thanks to Allahabad Society for involving me as a part of this prestigious webinar. And I'm really happy to see Manju Verma ma'am, as she is my teacher in my undergraduate days. I have done my MBBS from Allahabad Medical College. बहुत पढ़ाया है मैम ने, बहुत डांटा भी है, बट आई एम रियली हैप्पी क्योंकि टीचर्स ही होते हैं जो हमारी लाइफ को शेप करते हैं, कैरियर को बनाते हैं. And now it's my proud privilege to invite Lalita Shukla ma'am. She is a very sweet and very senior obstetrician gynecologist, very calm and very excellent person. And please share the CV. Yeah. Lalita ma'am ka CV.
Dr. Lalita Shukla CV.
Yeah. Dr. Lalita ma'am is currently the president of Allahabad Obs and Gynae Society and a very senior consultant and obstetrician gynecologist of Arogya Niketan Prayagraj, and she's ex-chairperson of AMA Women's Wing. So I welcome you, ma'am, for your talk.
Share screen then. Thank you, Mamta, for the kind words and the kind introduction referring to me. A big thank you to all the organizers of this meeting for including me in this session. And good evening to respected seniors and all the friends. Now we know that FGR is a very important topic and it is a cause of concern for both the patient, her attendants, and of course the treating obstetrician. So now coming to the causes and the reasons for IUGR. Now, what is IUGR? FGR, formerly called IUGR, refers to a condition in which the unborn baby is smaller than it should be because it has not grown at the normal rate inside the womb. It also refers to neonates whose birth weight is less than 3rd percentile. They are referred to as very small for gestational age, and less than 10th percentile, that they're small for gestational age, as against appropriate for gestational age, which is 10th to 90th percentile, and large for gestational age, which is above 90th percentile. Now coming to the classification, they can be type 1 is symmetric FGR. That is, the baby is symmetrically small and they have a normal head abdominal and FA ratio. Type 2 refers to fetus that have abdominal circumference less than the head circumference, resulting in a higher HA and FA ratio. Type 3 is intermediate FGR, when the fetus is initially symmetric but becomes asymmetric later on. Now coming to the incidence, it is around 3 to 7%. It is higher in preterm infants, which is around 16 to 43%. Full-term infants, 7.8%. It is higher in females, 12.7%. Males, it is 7.7%. Now, fetal growth, it varies with ethnic and geographical reasons. The ponderal index, that is the birth weight in grams upon crown heel length into 100, is one tool which has a high accuracy for identification of IUGR, which is independent of birth weight percentile, but it might miss proportionately small and lean neonates with growth retardation. Now, there are 3 parts of fetal growth. The first phase is hyperplasia, which occurs in the first 16 weeks. Up to 32 weeks, both cellular hyperplasia and hypertrophy occur. After 32 weeks, it's mainly cellular hypertrophy. So we can roughly say it is around 5 grams per day at 15 weeks, 15 to 20 grams per day at 24 weeks, and 30 to 35 grams per day at 34 weeks. Now the causes of IUGR can be maternal, placental, and fetal. So, but we see that the placental insufficiency, it accounts for more than 75 to 80% of the patients. The maternal conditions not associated with placental insufficiency is around 5%. Fetal chromosomal anomalies are 5%. Multifactorial fetal abnormalities are 2 to 3%, and fetal infections are around 1%. Now, the placental causes are mainly abnormal placentation, chronic villitis, placental infarcts, placental hemangiomas, chorioangiosis, hemorrhagic endovasculitis, placenta previa. So to know about the placental problems, we have to know about the normal placental development. Now, the successful placentation is required for the coordination of key components within the maternal, the placental, and the fetal compartments. Now, the first trimester blastocyst adherence and implantation initiates placental vascular development necessary for the delivery of nutrients and oxygen to the growing trophoblast beyond simple diffusion, which occurs initially. Now, successful adherence permits differentiation of placental transport mechanisms and activation of paracrine and endocrine signaling pathways between the mother, the placenta, and the fetus by the second trimester. A trophoblast invasion into maternal spiral arteries decreases the blood flow resistance in both the vascular compartments of the placenta. Angiopoietins, placental growth factors, and placental proteins are three essential regulatory substances expressed in increasing concentration during the early phase of placental vasculogenesis. In the fetal compartment, villous proliferation of trophoblastic trabecula is initiated by the 18th day of conception. By the 5th week of gestation, all the villi contain extraembryonic mesenchyme and capillaries in a villous stroma. So the target of all this placentation and the changes in placenta is to maintain a normal fetal blood supply for proper growth and proper development. So these vascular processes, maturation processes, result in low resistance, high capacitance vascular beds that allow increasing and matched perfusion of the maternal and fetal compartments. Intervillous blood flow is regulated mainly through paracrine factors such as nitric oxide, endothelin, adenosine release, cyclic guanosine monophosphate, and fetal natriuretic peptide. After successful placentation, approximately 600 ml per minute maternal cardiac output is matched to 400 ml per kg per minute fetal blood flow distributed over a term placental area exchange of 12 meters square. By the second trimester, placental activity consumes 40% of oxygen and glucose entering the uterus, leaving the rest for fetal use. This proportion decreases up to progressively until term. With establishment of placental transport system, endocrine signaling between maternal, placental, and fetal compartments help to coordinate the placental and fetal growth. Now, what all is required for the fetal growth? So we have to have substrate availability, placental perfusion in maternal compartment, endocrine or paracrine signaling, and perfusion and nutrient exchange in the fetal compartment. Now, the design of fetal circulation is unique because it has 3 shunts. The ductus venosus is a fetal vessel connecting the umbilical vein to the left portion of the inferior vena cava. The function of ductus venosus is to shunt the substrate-rich blood coming from the placenta via the umbilical vein to the heart. It diverts 25% of the blood to the heart, remainder being distributed to the liver. That is why in Doppler, the ductus waveforms can be detected, and it is sensitive to cardiac function, which in turn is adversely affected by chronic severe decrease in substrate or oxygen availability. In response to hypoxia, the ductus venosus becomes dilated. The glucose and amino acids reach the liver for glycogen storage and stimulate insulin release through fetal pancreas. Now, release of insulin growth factors 1 and 2 provides the major stimulus for fetal growth and differentiation. Leptin stimulates fetal pancreatic growth and transplacental amino acid transport. and affects fatty acid transport, and therefore it may be an important modulator of fetal body fat content and body proportions. Now, the normal placental and fetal growth is characterized by a sequential cellular hyperplasia, hyperplasia plus hypertrophy, and finally hypertrophy alone. The placental growth follows a sigmoid curve, plateauing early in gestation, then does the fetal growth curve. Between the 16th and 32nd week, between the 16th weeks and term, human fetal weight increases 20-fold. The maximum growth occurring in the 3rd trimester when significant body mass and particularly adipose tissue are accumulated. Now, since we know all the normal conditions, we come to the abnormal conditions, which may interfere with normal placentation and culminate in either pregnancy loss or IUGR. Now, these conditions, they affect the placenta, like nutrient and oxygen delivery to the placenta, nutrient oxygen delivery across the placenta, and the fetal uptake. When they're sufficiently abnormal, they produce growth restriction characterized by reduction in fetal size, and when they're early and severe enough, they reduce the cell number. Thus, the growth is retarded postnatally. In clinical practice, there's considerable overlap between the conditions that determine the manifestation, progression, and outcome of growth restriction. Now, usually earlier the onset of disease process, the more likely the fetus is to be symmetrically small. With a reduced cell number, the etiology could be severe maternal vascular disorder, fetal infection, or a chromosomal disorder. Many risk factors act synergistically. Now, for example, the adverse effects of smoking is doubled in a thin woman and further potentiated by poor maternal weight gain. Mild placental disease is likely to affect organ function and maturation at the cellular level with little perceivable growth delay. With more severe placental disease, fetal growth delay and adaptive organ responses become evident in utero. Exhaustion of placental and fetal adaptive process leads to decompensation with variable progression and manifestation in uterine organ, in fetal organ systems. Now, the mechanism of placental dysfunction, how it actually occurs and leads to IUGR. First of all, there's a decrease. The deficiency of maternal fetal exchange of nutrients, fluid, and waste can become suboptimal when there is a decrease in substrate transporters. There's increase in diffusion distance between the maternal and fetal compartments. A decrease in impedance to blood flow to the maternal and fetal compartment in the placenta, like thrombosis and infarcts. Now, typically, earlier onset placental dysfunction produces a more severe clinical picture with marked manifestations, whereas late onset delay, first manifesting in the 3rd trimester, may produce few clinically detectable findings. Now, if we come to the metabolic and cellular effects of placental dysfunction, oxygen and glucose consumption by the placenta is unaffected when the nutrient delivery to the uterus is only mildly restricted, and fetal demands can be met by increased fetal extraction. Fetal hypoglycemia occurs when uterine oxygen delivery and likely substrate delivery is less than a critical value. Insulin is important fetal growth factor. Fetal pancreatic insulin responses are blunted by mild hypoglycemia, allowing gluconeogenesis from the hepatic glycogen stores. At this stage, fetal glucose stores and lactates are preferentially diverted to placenta to maintain placental metabolic, endocrine, and nutrient function. As the nutrient supply worsens, fetal hypoglycemia intensifies and secondary energy sources are required. Proteins are catabolized to gluconeogenic amino acids. Decreased transfer leads to deficiencies of circulating long-chain polyunsaturated fatty acids and the inability to establish essential adipose stores. Hypoglycemia, hyperlactic acidemia, and growing base deficit correlate with the degree of fetal hypoxemia and protein energy malnutrition. In this setting, the fetal brain and heart get most of the nutrients. The combination of fetal starvation, modified endocrine milieu, and deficient tissue stores limits fetal growth and affects cellular and functional differentiation. Vascular and metabolic disturbances within the placenta lead to alteration in many organ systems. The response of in the compensated hypoxemic state, the fetal cardiac output is increased and autoregulation maintained. The response of fetal trunk and cerebral circulation to hypoxemia, they differ from each other. The peripheral arteries constrict, so the truncal resistance also constricts. The fetal cerebral circulation dilates in response to hypoxemia. The overall effect is an improved distribution of well-oxygenated blood to the vital organs. In contrast, blood flow to organs that are not vital for the fetal survival are decreased. There is progressive decrease in amniotic fluid volume after long-standing redistribution. Further, there are increased circulating levels of endothelin, arginine, vasopressin, norepinephrine, epinephrine, vasoactive intestinal peptides, and atrial substance peptides. So this increases proportion to the acid-base disturbance in the acid-base distribution. Now, a delay occurs in all aspects of central nervous system maturation in fetuses with IUGR with chronic hypoxemia. In chronic hypoxemia, there's a higher baseline heart rate with lower short and long-term variations. Progressive fetal hypoxemia is associated with gradual reduction in amniotic volume, fetal breathing, gross fetal movements, and tone. The placental dysfunction affects other organ systems also. Hypoxemia stimulated erythropoietin release increases red blood manufacturing both from medullary and extramedullary hematopoiesis. Placental platelet aggregation and consumption, they increases the risk of thrombocytopenia. Now, other organ-specific dysfunctions include thyroid dysfunction, there's increase of cortisol levels, vitamin deficiency, and immune deficiency. So now we come to the maternal causes of vascular insufficiency. Most of them are related to the placenta, which we have already discussed. And the cause is mostly by aggravating vascular insufficiency, limiting the availability of the fetus substances that affect the fetal growth. So there may be an alteration of maternal or fetal hemostatic system or vasoconstriction, causing ischemic infarcts and decreased infusion. Another factor that may be of importance in determining the placental and fetal response to altered maternal environment is the presence of hereditary thrombophilia. So the conditions which we all know are preeclampsia, chronic hypertension, chronic renal disease, chronic connective tissue disorders, diabetes with vascular lesions, sickle cell anemia, cardiac disease class 3 and 4, and multiple gestation. Now coming to the causes not associated with placental insufficiency. These include severe malnutrition, smoking, alcohol ingestion, and hemoglobinopathies. Maternal smoking and tobacco chewing reduces the fetal weight by between 150 to 400 grams. And alcohol injection is also a cause of IUGR. So now we come to the causes of fetal causes, which are there. The number one is chromosomal anomalies, fetal multifactorial defects, and inborn errors of metabolism and infections. It is the chromosomal disorders, which especially trisomy. Then the possibility of a fetal congenital disorder should always be considered in patients with idiopathic or unexplained FGR. The most common abnormalities associated with FGR are chromosomal, especially trisomy 18. The cause is not clear, but it may be due to alterations in placental function resulting in placental malnutrition. The viral infections associated with FGR are HIV and acute herpes simplex. So finally, we know all the causes and we come to the conclusion that the main cause of IUGR lands in the placenta directly or indirectly, with other causes holding a small share of this. Thank you for your patient listening.
Thank you, Dr. Lalita ma'am, for this concise, crisp, and clear deliberation. And now I request Dr. Andaleep Agarwal, Madam, to kindly conclude the session.
Good evening, my teachers, colleagues, and thank you, Ritu.
Ji, ma'am. Please go ahead, ma'am.
Good evening to my respected teachers, colleagues, and friends. At the outset, I'd like to thank my own society for inviting me today and making me a part of this CME. These days, because of the gloominess of the pandemic, it's a real pleasure to meet you all. And being able to meet my beloved AOGS family and also Vox is a real pleasure for me today. Now, thank you, Dr. Lalita, for such a lucid and brilliant talk on the subject of etiogenesis of IUR, which is a very common entity which we encountered so frequently. Incidents being, as you have already detailed, everything, there's nothing much left for me to say. Around 15% of our cases, we come across these cases very. So what I would like to say is that we all have to be a FGR conscious physician and be on the lookout to pick it up early in the high risk group of our patients, comprising of pregnancies with histories of RPL, stillbirths, IUDs, prematurity, unexplained neonatal deaths, women with all the causes, maternal causes. Dr. Lalita has already gone through it very nicely. So the major concern in FGR, small size of the baby. It's actually the fetal compromise and remote complications the baby in later life, which makes it a thing of concern. Timely identification is difficult but crucial for proper management and favorable neonatal outcome. As it has been pointed out, it is the second cause of perinatal mortality after prematurity. It has been extensively studied, yet still it baffles us a lot. Therefore, the focus should be on to evaluate screening approaches, to critically review the proposed management, surveillance regimens to be adhered to strictly. Timing and mode of delivery is a very crucial decision-making point. And lastly, the postnatal management of the baby in a good tertiary NICU is essential. And for this, throughout the antenatal period, we should keep on counseling the parents and the family, as it has been pointed out earlier also, that the baby may require a long time in the NICU. So with this, I think we should move on to the next session. And I invite my teacher, Dr. Verma and Amrita, to kindly go for the second session.
Thank you, Chairpersons, Dr. Mamta Singh ji and Dr. Andaleep Agarwal, Madam, for concluding the session so well. Now, I think we shall take up the question and answers and any queries from our attendees in the end of the session. And now we move on to our next session, the prevention of fetal growth restriction. And the speaker is Dr. Divya Agarwal. And to chair the session, we have a Guru-Shishya duo, Dr. Manju Verma ma'am and Dr. Amita Tripathi. Dr. Manju Verma ma'am, first of all, I want to pay my sincere regards to ma'am, and now I take the privilege to introduce her. Madam has served as a lecturer, reader, and a professor in state medical colleges of UP. She has written many chapters in 3 books and has published more than 50 papers in various national and international journals. Madam is a proud recipient of many awards, and to name a few, Shiv Narayan Gold Medal, BC Pant Gold Medal, Lakshmi Ratan Bronze Medal, and a very prestigious President's Gold Medal. Madam has delivered many orations and guest lectures in international, national, and state level conferences and has received 12 gold medals for best research papers. You are truly an inspiration, Madam, and we are blessed that you are here. And now I will introduce Dr. Amita Tripathi, Vice President AOGS, a person who is beautiful inside out and ever supportive. She is the co-chairperson for the session, and this is my privilege today to introduce her. She is the founder secretary of ISOPA Prayagraj. She is the chairperson of AMA Women's Wing. She is the vice president of Allahabad Obstetrics and Society in 2017 and 18 too. She has received Dr. D.K. Tank Reproductive Health Trophy during her tenure, and she was joint secretary during the national conferences at Delhi, Foxy BOH 2017 and SEMA 2016, which was held at Allahabad. She is director of Kalavati Women Healthcare Center, Allahabad. She has been guest speaker and panelist in various national level conferences. She has published many papers in Asian Journal of Obstetrics and Gynecology, Indian Journal of Obstetrics and Gynecology, and she's also been awarded with Vidya Bhasin Award for Best Paper Presentation, Dr. Kamla in Indian Society of Perinatology and Reproductive Biology. She also has special interest in high-risk pregnancy and reproductive endocrinology. She has organized adolescent health camps at various schools at Allahabad and periphery. We welcome you both, and I request Dr. Amita Tripathi to kindly introduce Dr. Divya Agarwal.
Thank you, Dr. Ritu, for such a lovely and detailed introduction. Good evening, everyone. And I thank Team AOGS for giving me this lovely opportunity. First of all, to share any platform with our guru, Dr. Manju Verma ma'am, is an extreme honor for me. And to giving this opportunity to where my dear friend and classmate, Dr. Divya Agarwal, President BOGS, is a speaker. I can't tell you how blessed and happy and proud I feel today to introduce Dr. Divya Agarwal. Her area of interest is fertility management, but she is a wonderful laparoscopic surgeon. She has been on the various posts and at Varanasi Obstetrics and Gynecological Society. She is an ICOG fellow. What is not written in this, that she was the star or the gem of our batch of BRD 1987. She topped in 2 professionals, and the time for a proud moment for our batch was that she topped the UP PGME exam overall. We all felt so proud of her. And what about her? She's a great friend. She's a person inside out. Today, she's going to speak on the prevention of IUGR. Dr. Divya, now the platform is all yours. Please.
I don't know. Good evening, everyone. First of all, I would like to thank the AOGS and Shukla and Dr. Ritu Sinha for giving me this opportunity. I don't know, after getting the introduction for Amita, I really, really overwhelmed. I don't know what to say. I can't express my pleasure exactly. And it is also a great honor for me that Dr. Manju Verma, she's my teacher, as we have done our PG from Allahabad. Allahabad is so close to us. It always gives us a smile whenever we talk about Allahabad. It always gives us a smile. We go on thinking about it, and we feel so excited whenever we talk about Allahabad. We talk about our teacher, because it is associated with almost 3 to 10% of all the pregnancies, and the perinatal mortality rate is almost 5 to 20 times higher for growth retarded fetus, and it is the second leading contributor to the perinatal mortality. And the 20% of all the stillbirth are because of the IUGR. The incidence of intrapartum hypoxia in cases of IUGR has been reported to be 50%. So the early and proper identification and management lowers its perinatal mortality and morbidity. Here is the reason why I'm presenting this talk. So the early prediction of FGR is important, as it can identify the women at high risk of FGR who may benefit from preventive interventions and close monitoring during the pregnancy. So in any disease, we know that there are 3 types of prevention. It is primary prevention, secondary prevention, and the prevention and the tertiary prevention. So coming to primary prevention, if the prevention is applied during the peri-conception period before the patient gets pregnant, then that type of prevention is called the primary prevention. For this, we have to know about the risk factors for the growth retardation. And the risk factors, most important is the history-based risk factors, which have been already elaborated by Dr. Lalita. It is the maternal demographics. Most important is advanced age. If the BMI of the patient is low, like the patient is underweight, malnutrition, if the patient is living in high altitude, severe anemia, hemoglobinopathies, and if the patient is being exposed to the various type of environmental factors like air pollution, heavy metals, and heat. There are certain medical conditions also like chronic hypertension, chronic kidney disease, systemic lupus erythematosus, inflammatory bowel disease, anti-phospholipid syndrome, and the progesterone diabetes. These are also predisposing the patient for IUGR. And the obstetrical history, the previous pregnancy affected by FGR or the preeclampsia, it is one of the very important history we must take. So all these factors, including this nulliparity, use of recreational drugs and the alcohol, assisted reproductive technology, and the multiple pregnancy, because it is also one of the important reasons for IUGR, and medical disorders, chronic hypertension, diabetes, and already explained, they can influence the fetal growth and causes the risk of FGR. The cigarette smoking is also a very common risk factor for FGR, and it reduces the birth weight by an average of 200 grams in a dose response manner. The study was conducted, and in a cohort of 2006, it was found that the maternal characteristic predicted almost 37% of women who can subsequently deliver SGA neonates. That is the birth weight less than 5%, 5th percentile. So what are the strategies for primary prevention? These strategies has to be applied so that before the patient getting pregnant. So we have to encourage the woman to start the pregnancy when the BMI is between extremes. That means the patient is neither underweight or obese. If the patient is malnourished or malnutrition, then we have to provide this proper protein and energy supplementation the patient should take. If the patient is anemic, she should be treated. Vitamin and mineral supplementation should be given. And if the vitamin D deficiency is there, it has to be corrected. As already explained, the cessation of smoking is also one of the important, although not very common in our country, but in the Western world, this is a very important factor. Avoidance of alcohol and the illicit drugs, and the minimizing the risk of multiple pregnancy, especially during the ART. Plus, if the patient is having a case of chronic hypertension, we should prevent and treat the hypertensive disorders. As already explained by Dr. Lalita, this type of infections like rubella, toxoplasmosis, they are also predisposes the patient for IUGR. So we have to minimize the risk of the infections. So it's better to give the vaccination to prevent the rubella early and counseling about the toxoplasmosis. Plus, if the patient is having UTI, it should be diagnosed and treated in a proper way. Now coming to the secondary prevention. The secondary prevention's aim is to detect and treat the disease before the patient develops the proper IUGR. If we diagnose and we predict that this patient might have this IUGR and we can correct it, then it will be very beneficial. For this, we have to, there are certain predictors for the secondary prevention, like the biochemical markers and the ultrasound markers. The biochemical markers are like low PIGF, low PAPA, high alpha-fetoprotein, and high SFLT1 to PIGF ratio, which I will explain later. The ultrasound-based markers are uterine RT pulsatility index PI more than 95th percentile, uterine and bilateral notching of uterine artery, marginal or velamentous cord insertion, two vessel cord, that means the single umbilical artery, and the abnormal placental morphology. Now coming to the biochemical markers. Although there is no role for routine screening of IUGR with the serum biomarkers, however, when the biochemical markers are being as a part of prenatal genetic screening, like if we are going for the double screening or double marker test or the triple marker test, this type of information can be used for the purpose of risk stratification for FGR. Because the placenta releases multiple factors into the maternal circulation from the early stages of the pregnancy, and the first trimester serum level of these factors have shown to be associated with subsequent placenta-mediated complications. So the PAPA, which we normally test during the double marker test, it has been found that the low levels of pregnancy-associated plasma protein A, that means the PAPA, which is a placental glycoprotein produced by the syncytial trophoblast layer, they have been found to be associated with adverse pregnancy outcome, including this FGR and the S small for gestational age. A meta-analysis including 32 studies and 1,75,240 pregnancies found that PAPA levels below the 5th percentile had a moderate association with the birth weight below the 10th percentile, with the odds ratio of 2.08 and the positive predictive value of 18%. It means the low PAPA is often considered as an indication for the closer monitoring of the baby for the fetal group. The other type of biomarkers are this elevated second trimester maternal, this alpha fetoprotein AFP, and they basically reflects the abnormal placental permeability, and they are also related to the FGR and sometimes in stillbirth. So if the combination of low PAPA in the first trimester and the high FP in the second trimester is particularly predictive of severe FGR. So we should be conscious. If we see that the PAPA level is low and the high AFP, then we should be aware, then we should do the close monitoring of these patients because they are at high risk of the FGR. The another factor is the elevated human chorionic gonadotropin, and the level greater than 2.5 MOM in the second trimester, alone or in combination with the high AFP, are also associated with increased risk of SEA. The other biochemical markers are the placental growth factor, which is basically a pro-angiogenic factor and highly expressed in syncytial trophoblast and the maternal endothelium. The impaired, if the placentation is impaired, it is associated with definitely the reduced placental production of this protein. That means the low first trimester PIGF levels have also been associated with the preeclampsia and SEA. There's basically a new marker. This marker is very useful if we are going for the risk calculator, Barcelona risk calculator, which I'll come later on. This is basically soluble FMS-like tyrokinase 1 or SFLT1. It is an anti-angiogenic factor, which is expressed in a variant of PEGF-R receptor 1. And this binds with PEGF and PIGF and blocks the angiogenic effect on this receptor. So if there is placental hypoxia or ischemia, that increases the production of SFLT1. So imbalance in two biomarkers, this SFLT1 and the placental growth factor, it has been shown in cases to be involved in cases of preeclampsia as well as the FGR. An elevated ratio of SFLT1 to PIGF is highly predictive of preeclampsia and its related complications like IGR. So this study shows that SFLT to PIGF ratio can identify the pathological pregnancy outcome such as IUGR and the preeclampsia. Now coming to the ultrasound markers. This most important is increased uterine artery resistance, and it basically reflects a failure of extravillous cytotrophoblast invasion, which normally occurs in a normal pregnancy, and the transformation of the spiral arteries. And this has been already explained in the physiology. And it is associated with the development of preeclampsia and fetal growth retardation. And the first and second trimester abnormal uterine artery Doppler, especially the mean PI index above the 95th percentile or early diastolic notch in either of the two uterine arteries have been shown to be associated with FGR. Although uterine artery Doppler shows promise, especially for the prediction of early onset FGR, but the current evidence does not support the routine screening with the uterine artery Doppler for FGR. Now coming to the other ultrasound markers, they are the abnormal placental morphology, and this is done by 2D ultrasound. In this, we focus on shape of the placenta, texture, and the cord insertion. If it is abnormal placental shape, means the placental thickness is above 4 centimeter or greater than 50% of the placental length, or if the placenta is heterogeneous and contains multiple echogenic cystic lesion, or if it is marginal placental cord insertion, that is, if it is within the 2 centimeter of the placental disc margin or velamentous insertion, they are the important ultrasound markers for the FGR. There are no large-scale prospective studies validating the use of placental morphology for the prediction of FGR. The placental volume is also a very good ultrasound marker, and it is measured by 3D or the 4D scan, and it is also a marker for complications related to defective placental function. The systemic review estimating the value of the first trimester 3D placental volume for the prediction of FGA has found a detection rate of almost 24.7% at a 10% false positive rate. So currently there is no single screening test sufficiently which are predictive of FGR, and now the investigations are underway to combine the various tests. So in the prospective cohort of 4,970 women, the combination of first trimester PAPE, beta HCG, and the maternal blood pressure and uterine artery Doppler performed in the first trimester had a detection rate of almost 73% for early AG, but only 30% for the late SCA. So this is a risk calculator which has been given by Fetal Medicine Foundation. And this application allows the risk for fetal growth restriction, that is birth weight less than 5th percentile, from a combination of maternal characteristics as well as the previous obstetric history and the findings at 11 to 13 weeks. MOM values for the mean arterial pressure and uterine artery PI can be calculated by the application which is already given in this section. So this is basically a risk calculator in which we see the maternal characteristic like age, weight, height, racial origin, and diabetes. Then what are the medical conditions like diabetes, hypertension, SLE, if there is the history of smoking, method of conception. Then we take the previous obstetrical history, like if it is nulliparous or which number of parity. And we have to, if there is a history of previous IUGR, we have to calculate what is the weight of the baby previous. And then we do the, put this fetal crown rump length, uterine artery, this PI value, mean arterial pressure, serum PAPE level, and the serum PIGF level, and then we calculate the risk for the IUGR. And these type of calculators really help to know how much risk is there. So there is another calculator. This is by Barcelona Hospital, which has been given. And this is, in this, two types of calculations can be done. Either, as I have told, this HFLT1 and PIGF value is very important because they can calculate the risk. If we calculate it, and then they can itself only risk by the SFLT and PIGF alone can get to know us what is the risk of the IUGR. But they can also, the risk can be calculated by a multivariable model without SFLT or PIGF ratio, and which again calculates the gestational age, estimated fetal weight, umbilical artery PI, uterine artery PI, and what are the risk factors. And they seeing all these factors, we calculate how much risk of the IUGR is there. So once we have predicted that this population is at high risk of IUGR, then what we have to do? We have to try to prevent this IUGR in these type of groups. For this, there are two types of model. It is lifestyle modifications and the medical interventions. So for lifestyle modifications, ideally all women should plan their pregnancy, adopting a healthy lifestyle and optimizing any medical conditions and their body mass index. Encouraging the woman to start the pregnancy when the BMI is between extremes, as already explained. It has been seen that insufficient gestational weight gain has been associated with increased risk of FGR. The Institute of Medical Guidelines 2009 that recommend that a total gestational weight gain of 12.5 to 18 kg for underweight women, 11.5 to 16 kg for normal weight group, 7 to 11.5 for overweight women, and 5 to 9% kg for the obese women. And then most important, if there is a history of smoking, then there should be cessation of smoking and the avoidance of alcohol. This study, we can see that while underweight was associated with increased risk of preterm birth, small for gestational age, and the low birth babies. So the women of childbearing age should maintain a normal body mass index before the pregnancy. And there was another study which reviewed the perinatal complications associated with maternal tobacco use. And this study found that the use of tobacco product by pregnant women is associated with placenta previa, abruptio, premature rupture of the membranes, preterm birth, IUGR, and the sudden infant syndrome. And almost 15 to 20% of the women smoke during pregnancy. It has been suggested that smoking is responsible for 15% of the preterm birth, 20 to 30% of the low birth weight, and overall 15% increase in overall perinatal mortality. There's another study given by AICOG, and this study also showed that smoking cessation at any point in gestation benefits the pregnant woman and her fetus, but the greatest benefit is observed with the cessation of if it is before the 15 weeks of gestation. And this is a study showing the maternal alcohol consumption and the low birth weight, how much drinking during pregnancy is safe. And it has shown that the relationship between maternal alcohol drinking during pregnancy and birth weight was examined in this study. And it was seen that consuming at least 1 to 2 drinks daily was associated with substantially increased risk of producing a growth retarded infant. And conversely, consuming less than 1 drink had a minimal effect on IUGR. So once we have done the lifestyle modifications, there are certain medical interventions too. But most of the studies on early prevention of placental complications have focused on preeclampsia, with the results often being extrapolated for the FGR due to the common pathophysiology, as we all know. However, today, other than lifestyle modifications, there is no medical interventions to prevent the FGR, but the aspirin is recommended for women at increased risk of preeclampsia, but there is some evidence that it may also reduce the risk of FGR because the same common pathophysiology is there. And in a recent meta-analysis of 45 trials that included 20,909 women at high risk of preeclampsia, the administration of aspirin starting at less than or equal to 16 weeks of pregnancy reduced the risk of FGR by nearly half, with higher doses of aspirin associated with a greater reduction, favoring a dose of 100 to 150 milligrams. As we can see in this study, which concluded that low-dose aspirin initiated in early pregnancy is an efficient method of reducing the incidence of preeclampsia and the IUGR. This is another study given by Cochrane Library, and this also shows that overall antiplatelet agents improve the outcomes, and at those doses that it means 100 milligram appears to be safe. There's another study which was presented in 14th World Congress in Fetal Medicine, and this literature suggests a dose response effect and a minimum of 100 milligram aspirin should be favored for the prevention of preeclampsia and IUGR. Data supporting the use of aspirin at 75 to 80 milligram for the prevention of preeclampsia and IUGR is very limited. So looking at the safety of aspirin and overlap in the risk factors and pathogenesis of preeclampsia and FGR, it is reasonable to recommend aspirin to women at high risk of FGR using the same regimen as used in cases of preeclampsia. This was given by FIGO guidelines, and the most international guidelines recommend 100 to 150 milligram aspirin to prevent the FGR at the high risk in women at high risk. Another drug which is used is low molecular weight heparin, and this adjunct role of heparin along with the aspirin, it is attributed to the anticoagulant properties and the prevention of placental thrombosis. It has other biological properties like anti-inflammatory, complement inhibition, and pro-angiogenic activities. This study presented in ultrasound in OBS and gynae, and this concluded that low molecular weight heparin improves the pregnancy outcome in women with a high risk of IUGR. However, the further studies are needed to evaluate the risk adverse effect. There was one meta-analysis, and this included almost 6 RCTs and a total of 848 pregnant women. And this concluded that low molecular weight heparin may be a promising therapy for recurrent especially severe placenta-mediated pregnancy complication, but further research is required. And there was another meta-analysis which was published in Lancet that showed that the low molecular weight heparin does not seem to reduce the risk of recurrent placentation, placenta-mediated pregnancy complication. However, some decrease in event rates might have been too small for the power of a study to explode. So to conclude, we say that based on the most of the up-to-date evidence, the low molecular weight heparin cannot be recommended for the prevention of FGR in the women at a high risk of placenta-mediated complications, and its use for the prevention of FGR should therefore be limited to the research settings according to FIGO guidelines. This is overall the recommendation which has been given by the FIGO. And there's a strong recommendation that women should undergo risk stratification for FGR at the time of first trimester antenatal visit using the history-based risk factors. There's also a strong recommendation that there is no evidence to support the routine use of biochemical markers for the prediction of FGR. However, when such information is available as a part of prenatal genetic screening, it can be applied. And another strong recommendation is that ultrasound-based markers and the multi-parameter algorithm have only a moderate predictive accuracy for the FGR. And the women at high risk for FGR should undergo close surveillance of the fetal growth starting at 24 to 28 weeks. This is a strong recommendation. The women should be advised that smoking cessation and the elimination of alcohol and illicit drugs can decrease the risk of FGR. Women should be advised on the association of insufficient gestational weight gain and FGR, and regarding this, their target weight gain range. There is a strong recommendation for this. And there is weak recommendation. There is insufficient data to recommend routine treatment with aspirin in all women at the high risk of FGR. Low molecular weight heparin is not recommended for the prevention of FGR in the women at high risk of FGR, and its use should be limited to research settings. This is a strong recommendation given by FIGO. Now coming to the tertiary prevention. Now the aim is to decrease, once the IUGR has already occurred, now our aim is to decrease the fetal morbidity and the mortality. In this, we have to apply the therapeutic strategies and the proper timing of the delivery so that we can reduce the morbidity and the mortality of the fetus. This part will be covered by our next speaker. The therapeutic strategies include nutrition supplementation, bed rest, maternal hemodilation, beta mimetics, sedatives, and ACL, this acetyl salicylic acid, sex steroid, atrial natriuretic. All these therapies are there, but therapeutic strategies are most of the time disappointing, and there is no specific treatment for this tertiary prevention. However, there are certain drugs like L-arginine, which is a nitric oxide precursor, and sildenafil citrate, which is basically the 5-phosphodiesterase inhibitor, has shown some promising role. The sildenafil citrate, what does it do? It induces the vasodilation through the inhibition of this PDE5. And this PDE5 is responsible for the degradation of cyclical GMP to guanosine monophosphate. And this, since we are inhibiting, this drug is inhibiting the PDE5, so it delays the breakdown of cGMP and it increases the vasodilation. It is useful in the fetal growth restriction in attempt to induce the vasodilation, and thus increases the uteroplacental perfusion. The sildenafil citrate also vasodilates the myometrial arteries, and it was associated with the increased fetal AC growth. As we can see, this study, which was presented in British Journal of Obs and Gynae, this sildenafil citrate, when it was given 25 milligram 3 times a day until delivery in the pregnancy complicated by early onset IUGR, and it showed that it was associated with increased fetal growth rate, odds ratio 12.11 and 95% confidence interval of 1.3 compared with the controls. So the randomized control data are required. Further randomized control data are required to determine whether it is effective or not. The another drug which we are very commonly using in our day-to-day practice, it is L-arginine. And this is this nitric oxide is the constituency produced in human vein amyloidosis and platelet from conversion of L-arginine to L-citrulline by the endothelial and NO-synthetase. And this, what does this nitric oxide do? It causes the cGMP mediated vascular relaxation and inhibits the platelet adhesion. So when this L-arginine, when it is given, it is basically a nutritionally essential amino acid for the fetus, and it is also a precursor for the synthesis of NO. So L-arginine plays a role in fetal nutrition and oxygenation, resulting in the improvement of IUGR pregnancy, enhancing the birth weight and decreasing the neonatal morbidity and mortality. This study, which was presented in Indian Clinical Biochemistry Journal, and this showed that acknowledging the beneficial effect of L-arginine on endothelial vasculature, the present study was designed to evaluate the efficacy of L-arginine on bioavailability of NO with respect to fetal outcome, and it shows that L-arginine can be used to increase the maternal NO level, enhancing the birth rate. Yeah, it's finishing. So just to in short, I would like to say that early prediction of FGR is important as it can identify the women at high risk of FGR. And these things already told that biochemical and ultrasound markers are good predictors for secondary prevention. And these type of calculators are really helping in patient counseling and management. Lifestyle modifications are helpful in prevention of IUGR, and the most international guidelines recommend 100 to 150 milligram aspirin to prevent the FGR. And there is no specific treatment studies for tertiary prevention. However, the L-arginine and sildenafil citrate have some promising role. As said by Benjamin Franklin, an ounce of prevention is worth a pound of cure. So here, that is why we know that once we can apply these prevention strategies, we can prevent IUGR baby, because God has big plans for all these small little babies too. Thank you.
Thank you, Dr. Divya. Thank you, Dr. Divya, for this wonderful presentation. And now I invite and welcome Dr. Manju Verma, Madam, to please conclude the session. Dr. Manju Verma, ma'am, please.
Yeah. Can you hear me?
Yeah, sure, ma'am. Yeah. Please.
At the outset, I would definitely like to thank the office bearers of AOGS President, Dr. Lalita Shukla and Dr. Ritu Sinha for making me a part of this webinar. I am an AOGS part, but at this time, I would like to say my thanks to both all the office bearers of AOGS. Then I would like to say that this is an era of pandemic of corona, and मैं चाहूंगी कि जो हमारे 26 लोग जिन्होंने हम लोगों ने लूज किया है इलाहाबाद से, उनको भावभीनी श्रद्धांजलि हम दें, क्योंकि कल भी कोरोना मार्टियर दिन मनाया जा रहा है, जो डॉक्टर्स डे मनाया जाता था बीसी रॉय की साथ साथ। तो सबसे पहले मैं उन लोगों को शत नमन करती हूँ जिन्होंने इस कोरोना पेंडेमिक में अपनी प्राण की आहुति दी है। तो मैं उन सबको अपनी श्रद्धांजलि अर्पित करती हूँ और उनको शत नमन करती हूँ। Now I would like to say that Divya, you've given a very interesting and very good talk. And as we know, this subject is a very important subject affecting at least 3 to 5% of all pregnancies. Then, 20% of the stillborn are growth restricted. This is a meta-analysis which has been found. And babies who are less than 2.7 kgs, 1/3 of their infants have restricted growth. And 20 to 30% of growth restricted fetuses are small due to pathological. It's only 20 to 30%. The rest of them we still don't know the cause of it. Small due to pathological restriction of growth, and perinatal mortality is high in these patients, counting to 8 to 10 times higher than the fetuses, the normal fetuses. And it's not the immediate problem that is much should be taken into consideration. There are long-term effects also of IUGR, because these children, these fetuses are prone to have cerebral palsy, hypertension later on in life, dyslipidemia, diabetes mellitus, breast cancer, prostate cancer, and mental health problem and academic impairment and poor general health. So this is not only that we are concerned that the baby should be born healthy. We have to ensure that they have a normal life later on also. Now, I would like to just share, Divya, one thing, that you've nicely elaborated all the risk factors, but now there's a risk scoring. We have divided the risk into minor and major risk factors. So that if you detect by history, when the patient comes to you for the first time or comes even before, so if you stratify the risk And I will just take 5 minutes to elaborate that the and how they should be monitored. The minor risk factors are basically maternal age more than 35, and IVF pregnancy, nulliparity, a BMI between less than 20 or between 25 to 34.9, smoking 1 to 10 cigarettes per day, previous history of preeclampsia, pregnancy interval of more than 6 years, less than 6 months, because I have 2 patients who have delivered in 9 months. So this is one of the factors which one has to take. Then it is the pregnancy interval for more than 60 months, that means 5 years. So these are the minor risk factors. And if 3 or more of these risk factors are present, then one has to do an uterine artery Doppler at 20 to 24 weeks of gestation. Now, if it is normal, then the fetal assessment is done as a normal pregnancy otherwise, and Doppler is done in the 3rd trimester. Now, if the uterine artery is the study is abnormal, then this has to be treated like a major risk factors present. So I will detail it later on. The major, to enumerate, the major risk factors are previous stillbirth, chronic hypertension, renal disease, diabetes, vascular changes, maternal age more than 40, then prenatal history of prenatal small for gestational age baby, smoking more than 11. Minor was 1 to 10, major is more than 11. And we should not think that where the Indian women are not smoking. All the laborers, they smoke bidi. So it's a very strong factor even in India, smoking. Then it is the heavy bleeding during pregnancy and a PAP-A if it is being done, and if it is less than 0.4 MOM, this becomes a major factor. Then cocaine use, daily vigorous exercises, phospholipid syndrome. Now, these are the major factors. And even if one factor if it is present, then the lady is at high risk for the FGR. And this one has to start. Now, the studies are coming on that the aspirin, if it is started before 16 weeks, ideally around about 12 weeks, but 16 weeks, because that is the time when the placental changes occur and there are changes in the vascular pattern. So then the fetal, serial assessment of fetal growth, umbilical artery Doppler has to be done more frequently. The clinical visits have to be more frequently. So this is how, when a patient comes and we classify them simpler way, that these are major, minor 3 factors present or major 1 factor present. And then we can manage later on how it has to be done. So this is a risk management which has come. And I would like to say, Divya, very nice. And Lalita, your, she has already said all the medications which can be done. And nowadays the trial is going on for the statins also, in addition to what you have said of aspirin, then low molecular weight to heparin, then it is the sildenafil and L-arginine. Now the recent is coming as a statins, because we know there is a metabolic syndrome that is going on, and we all know that metabolic syndrome has to be treated with these statins. So there are certain studies which are saying that there's a reduction in the IUGR if the statins are used. So I would like to say thank you very much, Ritu and Lalita, and my dear students. I think more than 50% are my students. Amita, Divya, Mamta said they remember Mary Dart. I know. I was a strict person. I am a perfectionist. So I used to lose my temper on you people, so that you can also be perfectionists. So again, I wish you luck and prosperity and rise high and high, because for a teacher, the most, something which really means to the teacher is that the student of the teacher should be more than what the teacher was. So this is what I would like to say. And thanks a lot, everyone. And even the Sandeep, Rashmi, and and Ms. Rajat of Akumentis, because we have been closely associated with the company, and I would like to say thanks to them also for arranging the webinar. Thank you. Thank you very much, everyone.
Thank you, Thank you, Chairpersons, Dr. Manju Verma, Madam, for your pearls of wisdom. And thank you, Dr. Amita Tripathi, for chairing the session. So now, after finishing the etiopathogenesis and prevention of FGR, now we come on to once the FGR has developed, what is the role of obstetrical Doppler in its management? And to deliver this talk, we have a very dynamic and learned speaker, Dr. Anupama Ravi Futela. Our chairperson for this session is Dr. Madhvi Mittal, Madam. She is a renowned radiologist of our city, a thorough academician, and ever supportive. It's my privilege to welcome you, Madam. Madam has done her MD in radio diagnosis from AIMS, New Delhi in December 1986. She has more than 30 years of experience in sonography. She's consultant radiologist at Ultrasound and Breast Imaging Center, Allahabad. Her main field of interest are women's imaging and fetal medicine. We welcome you, Madam. And now I take the opportunity to welcome my friend, Dr. Pushpa Pal, Director of MGM Hospital, a renowned gynecologist of our city, a cheerful person, and a multidimensional personality. She'll be chairing the session along with Dr. Madhvi Mittal. We are privileged to have you both on board, and now I request Dr. Pushpa Pal to kindly introduce Dr. Anupama. Dr. Anupama, Dr. Pushpa?
Yeah.
Yeah, please go ahead with introducing Dr. Anupama.
Okay. Thank you, Dr. Ritu. First of all, there is my great regard to my teacher and my mother, Dr. Manju Verma. And I'm here because me and my kids are here because of her. So I have no word to say anything for her. And my great regard to my seniors, Ranjana Didi, Anleep Didi, and Lalita Didi, and my dears, Divya, Anupma, and Ritu. And it's a very great surprise that we are having two series of batchmate here from 87 batch. I and Dr. Anupma and Ritu from 87 batch for KGMC, and Dr. Divya and Dr. Me, and we are from here as a PG student. And thank you, Ritu. You gave me this opportunity to introduce our dynamic lady, Dr. Anupma Ravi Futela. We know her since 1987 when we were all doing MBBS from KGMC Lucknow. She is graduate from KGMC Lucknow, done her master from Maulana Azad Medical College, Delhi. She completed her fellowship in reproductive medicine from Singapore. She is an honor and senior consultant of Futela Hospital, Rudrapur, Uttarakhand. She is a founder president of Rudrapur Obstetric and Gynecology.
Cut it short, Pushpa, cut it short. I am your friend, that's enough.
Okay. No. Chota sa.
Go ahead. Now we also want to know about your credentials.
She is a pioneer in infertility in Kumayu, and she gifted the first IVF freebie there. And she honored as a faculty in various local, state, and national conferences, conducted many workshops, and participated as a panelist. She conducted gynae ultrasonography and IUI training workshop at her own center. She is an excellent orator and motivational speaker and co-founder of Bhor NGO. And she contributed in chapter in Foxy publication, a handbook of drugs in infertility last year. And now I'm inviting Dr. Anupma for her lecture. And the topic is color Doppler and management of fetal growth retardation. Go ahead.
Thank you. Thanks a lot, Pushpa, for your kind words. First of all, I would start with saying that I have been born in Meerut. I've been brought up in Gorakhpur. I studied in Lucknow. I'm settled in Rudrapur. And there were two cities which I have बचपन के संस्कारों से जो दो शहर मुझे हमेशा से लगते थे बहुत पढ़ाई लिखाई और पंडित्व वाले शहर थे, वो काशी और इलाहाबाद हैं. और आज मुझे प्रयाग और काशी ये दोनों के साथ में इंटरेक्शन करने का मौका मिल रहा है। मेरा प्रणाम सब लोगों को और बहुत बड़ा सारा हग के साथ थैंक यू मेरी प्यारी रितु को, who has allowed me to participate in this event. It has been my passion to teach, and I love to interact with my colleagues and dissipate whatever knowledge I have taken. And before starting, I wanted to tell that Pushpa has been my batchmate, and she was one person जिसने मुझे हमेशा हराया है. हम लोग कॉलेज टाइम में डांस कंपटीशन बहुत हुआ करते थे, और वो डांस कॉम्पिटिशन्स में हमारी पुष्पा रानी जो है सबको हमेशा उन्होंने हराया है. एंड आई एम प्राउड, I'm really proud to be one of her batchmates, and it was so overwhelming to hear words from Pushpa. Manju madam and all the office bearers here, Lalita ji, my dear Divya, the other speakers, Lalita madam, aap sabhi ko bahut bahut thank you. And Sandeep ji, with your, I know I have given you a pain in the neck yesterday by insisting on changing the platforms. But then thank you so much, because that is how the session would be comfortable. All us very well-read speakers have spoken much about IUGR. I will start. Bottom line is this कि IUGR में management के लिए करने को बहुत ज़्यादा कुछ नहीं है. Preventive roles थोड़ी बहुत चीज़ों के हैं, लेकिन जिस चीज़ का पक्का कोई role है वो है how to time the delivery. So to time the delivery, earlier there were not much parameters. The pubic symphyseal height was one thing, or related to that लाइकर कैसा लग रहा है हम लोग assessment करते थे. Gradually ultrasound was an aid, but then over the time when Dopplers came in, then they really changed the scenario of FGR management. Now instead of IUGR we call it as FGR, and how Doppler changes the FGR management, we'll share it gradually. Before going ahead with the FGR management, I would want to first of all talk a little about Dopplers, how we go about Dopplers, because Doppler is one thing which any gynecologist present here who's less than 40, I would say every lady who's less than 40 has to know how to do Doppler. If they have not yet learned, please learn it. And anybody more than 40 and he is actively doing practice has to learn what do you see in Dopplers. अगर आप नहीं कर रहे हैं तो भी आपको कुछ चीजें पता होनी चाहिए. मैं सिर्फ 2 स्लाइड में बेसिक फिजिक्स बताने वाली हूँ डॉपलर की, and I will be really honored if you will go back little bit more enriched after the talk today. I'm sure यहाँ पर सब learned ही हैं, लेकिन आई एम ऑल्सो श्योर कि हर बार कुछ ना कुछ, हर सेशन से कुछ ना कुछ सीखने को मिलता है. देयर विल बी समथिंग मोर व्हिच वी लर्न फ्रॉम दिस सेशन. ओके, सो द फर्स्ट थिंग व्हिच आई वांटेड टू से वाज दैट डॉपलर क्या चीज है. जब अल्ट्रासाउंड हम कर रहे होते हैं तो जो अल्ट्रासाउंड का प्रोब है वो सिग्नल्स भेजता है, और सिग्नल्स भेज के जो साउंड वापस ट्रांसमिट होती है उसको रीड किया जाता है. सो जो सिग्नल गई और वो सिग्नल वापस आई, अगर वो वैसी की वैसी वापस आ गई तो there is no change, there is no variation. There is like this in this stationary one. Okay, and if this is the stationary one, if by any chance जो अल्ट्रासाउंड वेव्स टकरा रही हैं वो किसी ऐसे ऑब्जेक्ट के ऊपर टकरा रही हैं जो कि मूविंग सिग्नल है, तो वो मूविंग सिग्नल अगर टुवर्ड्स द प्रोब मूव कर रहा है तो वो रिटर्न सिग्नल्स ज्यादा पास आएंगे, और जब वो ज्यादा पास आएंगे तो देयर विल बी अ फ्रीक्वेंसी शिफ्ट. दैट फ्रीक्वेंसी शिफ्ट इज रेड बाय द प्रोब, translated it into a graph, and then we see that graph. If that moving particle, in this case here in obstetrics and mostly in Dopplers, we study the moving blood vessels, the blood cells in a vessel. ब्लड वेसल के अंदर बहुत सारी लाखों आरबीसीज चल रही हैं. वो आरबीसीज की मूवमेंट को हम रीड करते हैं थ्रू दी डॉपलर सिग्नल्स. सो दैट फ्रीक्वेंसी शिफ्ट व्हिच वी आर लुकिंग एट is is the Doppler signal, and हम सबको ये Doppler signal सीखने हैं. आज इस सेशन के बाद में एटलीस्ट अम्बिलिकल आर्टरी और MCA का ग्राफ हर किसी को देखना आना चाहिए. We'll go through it one by one. This is the second slide. बस सिर्फ 2 फिजिक्स की स्लाइड्स हैं. This is the second slide. Now just imagine एक वेसल ऐसे जा रही है. This vessel is going here and the blood is going from here to here. So what is happening is the RBCs are moving towards the probe. ये स्किन है, ये ऊपर से प्रोब के सिग्नल्स आ रहे हैं. ये जो सिग्नल्स आ रहे हैं इस पर वेसल के ऊपर जब ये आए तो हमारी जो वेसल्स इस तरफ मूव कर रही है, वेसल के अंदर आरबीसीज, इन्होंने सिग्नल शिफ्ट ज्यादा दिया. सो जब सिग्नल शिफ्ट ज्यादा होगा तो हमें वेव्स बड़ी बड़ी दिखेंगी. जब ये सिग्नल वेव्स थोड़ा सा टेंजेंशियल हो गया तो हमें यही पीक जो है थोड़ी सी कम दिखाई पड़ने लग गई. जब ये प्रोब हमारा 90 डिग्री पर पड़ रहा है तो इसने बहुत कम चेंज दिखाया. रिटर्न वेव में सिमिलर चेंज आते जाएंगे. जब ये पैरेलल हो जाएगा रिटर्न तो बड़ी अच्छी वेव्स आने शुरू हो जाएंगी. बॉटम लाइन में क्या कहना चाह रही हूं कि जब आपका सिग्नल आपके वेसल के ऊपर पड़ रहा है तो अगर आपकी वेसल पैरेलल टू द स्किन है देन इट इज नॉट गुड. आपकी वेसल जो है वो पैरेलल टू द प्रोब होनी चाहिए. ये डायरेक्शन होनी चाहिए आपके वेसल की. So whenever you are doing your Dopplers, make sure that you try and select a vertical vessel. That is the whole thing which I am trying to say, and try to make the angle as less as possible. Close to 0, if not 0, close to 15. If it is more than 15, try and change the angle later on. It should not be close to 90. Okay? Okay, so now we'll just talk about what are various types of graphs there. मोटा मोटा 4 वेसल्स हैं. अभी we'll elaborate more, but मोटी मोटी 4 वेसल्स हैं जिनके की ग्राफ्स हमें स्टडी करने होते हैं. यूट्राइन आर्टरी, अम्बिलिकल आर्टरी, MCA एंड डक्टस वेनोसिस. राइट. सो फर्स्ट ऑफ ऑल हम लोग यूट्राइन आर्टरी के ग्राफ को देखते हैं. कोई भी वेसल का डॉपलर का ग्राफ जो है वो कैसे कैसे हो सकता है. इट कैन बी अ मोनोफेजिक ग्राफ. मोनोफेजिक ग्राफ इज समथिंग लाइक दिस. ऐसे चल रहा है ग्राफ. ऐसा ग्राफ हमें ऑब्स्टेट्रिक्स में कहाँ दिखता है? इट इज इन द अम्बिलिकल वेन. अम्बिलिकल वेन में हमें ऐसे सिंपल एक वेसल आराम से चल रही है, उसमें कोई पीक्स एंड ट्रफ्स नहीं है. ये हमारी अम्बिलिकल वेन की ग्राफ है. कभी कभी अम्बिलिकल वेन इज जस्ट एडजेसेंट टू द अम्बिलिकल आर्टरी, और कभी कभी व्हेन दे आर बोथ मूविंग पैरेलल they are always in close proximity. So early in pregnancy sometimes you can find a graph of umbilical vein like this, a little pulsatile graph, and you can say that it is a biphasic graph, but actually it is a monophasic graph with little pulsations in between. They are actually the transmitted pulsations from the uterine the umbilical artery, so that is why you see a little bit of pulsations there. But the most common type of graph which one will see in obstetrics would be the umbilical artery ka biphasic graph. Now how does this graph goes? When there is an early pregnancy, at that time the umbilical artery is like this. Systole mein to bahut sara flow hai, diastole mein there is nearly no flow. This is the kind of graph in early pregnancy. As the pregnancy advances, the graph will grow like this. You will find more and more and more of flows. Systole ka flow is more or less the same, but the umbilical the umbilical artery diastolic flow keeps on increasing. Can you appreciate? The umbilical artery diastolic flow is increased. This is the systolic flow, and this end part is the diastolic flow. So the diastolic flow is gradually increasing. Earlier it is nearly nil. Then there is another common biphasic graph that we come across, and that is of middle cerebral artery. How does the graph of a middle cerebral artery goes? That graph is usually this kind of a graph. Big peaks are seen. Big peaks are seen. This kind of graph is that of a middle cerebral artery, and there is very less diastolic flow in a middle cerebral artery. Always try to look in your patient's reports, always try to look at the graphs, and then you will gradually have an idea what, and always look at this diastolic region, what and how much flow is there. Okay. Then there is another artery, which is uterine artery. How does the uterine artery graph goes? Uterine artery is, to start with, it is something like this. In systole, the graph goes like this. And then in diastole, the graph goes like this. You can already appreciate that the blood vessels, the distance against the time is different in uterine artery and in the umbilical artery. We know the reason, because this is reflecting the fetal circulation and this is the maternal circulation. The pulse rate would be lower in maternal circulation. So as the pregnancy advances and there is increased trophoblastic invasion, gradually the uterine artery flows would improve, and this would be the kind of uterine artery graph which we'll find at the end of the pregnancy, where gradually this portion is the systole and this portion is the diastole, and we can see an early diastolic notch here. As the pregnancy advances, this early diastolic notch will flatten and then gradually disappear. So this is how a usual graph of uterine artery would look like. If by any chance, when you are looking at a uterine artery graph and you get this kind of flow, big peaks with maternal pulse, heart rate is same 80-90, but this is a big peaks, then you know that this is a triphasic graph of a iliac vessel. Actually, it is not the uterine artery graph, and this is the iliac vessel. So you have to, they are actually at cross section to each other. So you are insonating the wrong vessel. So change your vessel and then you will find a correct vessel, that would be the uterine artery, to take the colors. Okay. So these are the common vessels which we look at: the uterine artery, the umbilical artery, the middle artery, middle cerebral artery, the ductus venosus. Okay, I actually missed drawing the ductus venosus. Ductus venosus is one vessel which indicates the fetal circulation, and this vessel is present. It is the pure blood going to the baby. Okay, so the pure blood has to be in its maximum for a baby to be a good baby, right? So a ductus venosus graph goes like this. This is the fetal, the systole part, and this is the diastole part. Then again, this is the systole part, and this is the diastolic part. This is the systolic part, and this is the diastolic part. Now, what is the difference here? The difference is that here, apart from a S and a D, S is the systolic distance, peak systole, D is the diastole. There is another thing present over here, which we call as a wave. When there is end of diastole, at the end of diastole, normally what happens? See, imagine that this is the fetal heart and the ductus venosus is pushing blood here. When the ductus venosus is pushing blood here, when the heart is contracting, okay, when the heart is contracting, at that time, this is the contraction time. At that time, whenever there is a contraction, it is actually the ventricular contraction. So then when the ventricular contraction is occurring, what is there behind the ventricle? It is the atrium. And what is behind the atrium? It is the ductus venosus. So when there is a contraction at the level of the ventricle, the atrium is relaxing at that time, right? There is a diastole of the atrium at that time. So just imagine it for a minute. It might look difficult, but this is important to understand a ductus venosus. At the time of the systole, there is a diastole occurring at the atrium, and the ductus venosus is pushing more blood over there. So at the time of systole, there is a lot of blood going on in the heart, and there is good flow at the level of the ductus venosus. Now, when diastole is occurring, that is the time of atrium to contract, and atrium contracts towards the end of the diastole. So at that time, when the atrium is contracting, there should not be any blood going from the ductus venosus. But the ductus venosus is still pushing blood. What does this indicate? That when the heart is contracting, even at that time, the ductus venosus is managing to push blood towards the general circulation. So that means this is a good heart. It is functioning very well, right? So this atrium, this A wave of the atrial contraction is the one which we are looking at. As the pregnancy would deteriorate, the bad pregnancy is occurring, there is a lot of FGR. I am elaborating it so much in detail because this is what actually matters. The ductus venosus graph should ideally be like this. But if with increasing time, the ductus venosus graph goes like this, then that means there is absent A wave. And over the time, it will go like this, which means it is a reverse A wave. And this is the point of final termination. The baby is going to die now. Ab to kuch nahi kar sakte, ab nikalna hi. Okay. So that much about the vessels. And aortic isthmus is another vessel which has come up lastly for last 2-3 years, and people have started using it. Umbilical vein is usually a monophasic graft, but sometimes a change occurs at the terminal stage when the umbilical vein pulsations would start at the very terminal stage of a retarded baby. And inferior vena cava again is not so important right now. Okay, fetal circulation is one more important thing to understand before we understand the Dopplers clearly. We know that everybody has very good concept about the fetal circulation, but just again for a small revision, let me sketch a fetal heart here. And the fetal heart has these 4 components: the right atrium, the left ventricle, and the right ventricle. And behind this right atrium is the vessel, which is ductus venosus, and it is getting blood from the umbilical vein. So this umbilical vein is pushing good blood, and it is going through the umbilical vein is bypassing its blood from the ductus venosus directly into the right atrium. Now, just understand this, that how heart is placed. The maximum pure blood, which is of maximum oxygenation, which is coming from the umbilical vein, is going here, reaching through the ductus venosus into the right atrium. And usually in an adult, this shifts here in the right ventricle. But in a fetus, most of this pure blood, it is lying in this direction, that the jet of this pure blood goes directly to the left atrium through the foramen ovale. And that blood goes through the left ventricle to the brain, to the organs which are requiring the maximum oxygenated blood. And what are those organs? The coronary supply and the cerebral supply. So that coronary and cerebral supply would be done through this area, and this blood is coming directly here, not getting mixed with anything. There is a pure jet of blood coming here, going here, and reaching the brain and the heart musculature. The blood which is coming from the superior vena cava into the right atrium, that blood usually doesn't get mixed with this, because the jet and the force of the blood is so much through the ductus venosus that goes directly here, and the impure blood which comes here comes through brain. This good blood has reached the brain, and then from there the superior vena cava makes it reach here, and from here it reaches the right ventricle, and from the right ventricle it is sent to the pulmonary circulation. And since the pulmonary circulation doesn't require any blood, there is no oxygenation happening there, so all that blood is getting shifted from the ductus arteriosus into the systemic circulation. And the systemic circulation gets that instead of this 100% oxygenated blood, it is getting mixed with this, it is getting impaired by the brain and then coming to the right ventricle and then going towards the rest of the body circulation. And that blood which is reaching the whole of the body is not the 100% oxygenated one, rather it is the 70-80% one. And then that blood, when it travels through this, then after that, it goes back through the umbilical arteries to the placenta. Now, umbilical arteries are the two arteries. So here in this picture, you can easily see that this is the placenta, which is sending the good blood from the, this big red one is the umbilical vein, and this umbilical artery is less pure blood, which we are seeing. Okay, so the whole picture starts from here. And first of all, we learn how to do a uterine artery graft. That is the first vessel to be studied early in the pregnancy, when no other vessel is studied, like umbilical is not studied, the MCA is not studied, it's a teeny weeny baby. And at that time, which vessel would you want to study? Just now, Divya has told us about the preventive importance of the uterine artery Dopplers. So how would we do a uterine artery Doppler? First of all, let the patient lay, there's a small video that I'll play. I'm just enumerating 2-3 sentences that first of all, let the patient lay down in a comfortable position, a semi-recumbent or little tilt towards one of the sides, whichever makes patient comfortable. And then put your probe into the center of her lower abdomen and then tilt your probe towards one side at a time. Say first you are taking the right side, then go towards the right side, and your probe angle should be little towards the caudal and medial. This should be the position of your probe. The probe should direct towards the pubic symphysis region of the patient. That way you have to place the probe, and there you will find in the para-uterine area, you will find the uterine arteries. So that's the video. Now we are looking for the Dopplers of the uterine artery. For that, I will go outside the uterus, then on the colors. We see a cross section. I'm looking at two vessels which are crossing each other. Since I'm not sure that which vessel is the uterine artery and which one is the IL, I bring the graph. And this is the graph on the pulse wave. This tells me that this is a graph of the IL. Now I'm shifting to the other vessel, which is the uterine. Setting up the baseline. See, this is such a good flow. And I'm now taking the indices of the uterine artery. And this is showing a very good PI value of 0.6. This was the right side uterine artery which I have taken. We should also take the other artery, the left side, and then we have to put it in the measurement Barcelona criteria and then calculate accordingly. Or you can take the mean PI of the child. My presentation is not moving ahead, Sandeep ji. Am I audible?
Yes, ma'am, you're audible.
Something happened. It is not moving.
Can you stop it and share again?
Okay. Stop भी नहीं हो रहा है. अच्छा, हुआ. Is the screen visible again?
Yeah.
Yes, yes.
First of all, we are looking for the uterine arteries. So I'm at the center of the uterus and I'm going to the right side, and that is the outside of the uterus, and putting the color window and get the vessels. First, I have put in the color on this vessel, and this you can appreciate is a triphasic flow, which indicates that this is the iliac vessel. That is not the uterine artery, which I want. These uterine artery graphs are very important because they are one of the predictors of IUGR. And later on, you understand when I'll go ahead that how many calculations depend on the percentile of this PI value. So out of all the indices, what is really important to understand is the PI one. This is more perpendicular as compared to the previous one. Sorry, more parallel as compared to the previous one. We can appreciate a very good diastolic flow again in this uterine artery. This is the right side uterine. You can appreciate how much diastolic flow is there. This whole thing is the diastole. This is the end diastole. Now this is the opposite side uterine artery. Left side. This is the left uterine artery. I'm just wanting to tell you that look at the graph difference between the two sides uterine artery. You could see a very good graph on the right side, but on the left side, see, there are small diastolic notches here. So anyone can guess that what could be the reason? Notching over here? Well, the reason is that the placenta is more onto the right side. So the trophoblastic invasion has taken place more onto the right side rather than on the left side. That is why on left side the peaks are still there and right side is showing very good blood supply. This is again a good flow, but the PI values here are 1.84. So you can see the difference. There's a huge difference there between the right side and the left side. So what do you think would be the reason? So that makes us understand that if there is a very good flow on one uterine artery, that is a level of PI values of 0.6, and the other side is showing the level of 1.8. So in such a situation, you have to take the average, the mean PI in that particular patient. Okay. So now I'll move to the next vessel, that is the umbilical artery. This is the one vessel which is most majorly studied. And whenever you start learning your Dopplers, this is the vessel you should try your hands on. And uterine artery is having a little learning curve. So come to your uterine arteries a little later. First learn the umbilical arteries, then the middle cerebral arteries, and lastly the uterine arteries. So on an umbilical artery, the first thing which you have to learn is you have to try to insunate a vessel which is more or less a free vessel, not close to the fetal abdomen and not close to the placenta, because they would be, although they are little quiet vessels with less movements, but they are the values are usually not the average ones. So try to take a middle segment blood vessel, and again the vessel should be as parallel to your beam as possible. Now I am doing Dopplers for the umbilical artery. For umbilical artery, I am first localizing a good pocket where the vessels are visible. And this is a fairly good pocket where I can see the umbilical cord. And this is the place where the cords are there. I'm putting on the color. And I will try and look for a vessel which is parallel to the window line, the line which I am producing. I am trying to look for a vessel which is more parallel to it. Okay, it's like in this pocket. Also, while doing Dopplers, we should try to do it more at the time when the baby is in a quiet state. A lot of breathing movements from the end of the baby is not a good time.
Sorry, the pulse wave. And corrected the angle back to its original.
Fetal breathing movements are there. The mother's movement are there.
Ask the patient to hold her breath. Now you can see that it's a very good graph. Now I'll take the measurements. This is the auto trace. Now you can see that this PI value is 1.2 here and SD ratio is 3.5. So at the period of gestation of 55, this 3.5 SD ratio tells me that I should repeat it after a week again. PI value is definitely less than her FCA values, which was 1.52. So the cerebroplacental ratio is good, and I'm okay with this finding. Now, next we'll look for the umbilical artery graph.
Okay, we are done with the umbilical artery graphs. This was the easiest graph which anyone could get. I want you to now next look at the percentile, 50th percentile values of the umbilical artery graph. The umbilical artery, we usually look at three values, the SD ratio, the PI and the RI. Now the standard practice is that of PI. So one should not be very confused, but our old teaching was with the SD ratios, and if the levels of SD ratio is more than 3, we are usually concerned. If SD ratio is more than 6, we are very concerned and we have to deliver the baby. So that was our old teaching. But just to give you a picture, I wanted you to see that around 30 weeks, the 50th percentile is around, the SD value is around 2.8, and at around 40 weeks, it is 2.1. So gradually it is decreasing. The SD ratio more than 3 would make me concerned and tell me to repeat the Dopplers of this patient. The PI values, again, look at the 50th percentile. Around 30 weeks, the PI value is around 1, and then gradually it is decreasing. So I'm usually finding the PI values less than 1 only. So if there is a PI value definitely of more than 1.5, I'm very, very worried. Because if you look at the 95th centile in this patient, then you will see that nowhere it is more than 1.5. And always we are looking for the centiles now. The modern Doppler studies are more talking about the centiles rather than the values. So this is what we have to learn today as a new change. This was not the practice 5 years ago, but now we are talking more and more in terms of centiles. So now what usually happens in umbilical artery when it is pathological? Pathological umbilical artery would normally this kind of graph. Normally, you know what, the umbilical artery graph to start with is like this and gradually improves like this, and further a good seesaw pattern is there. But now if there is a diseased placenta, then gradually the diastolic flows would be lesser, and gradually absent diastolic flow would be there, and even later the reversal of the flows would be there. This is how we look at a worsening disease, from decreasing diastolic flows to absent diastolic flows to reverse diastolic flows. In such a situation, the PI values would be gradually increasing. Okay. Now, middle cerebral artery, short video again.
Now I am taking the graph of MCA. For that, the vessel which is most easily localized is the cerebral artery. That is the thickest vessel in the brain.
It's very early and a small features, and at this time we usually don't take the at 19 weeks the middle cerebral artery, but
which is farther
for
off,
this shooting Ritu has insisted that I should post
distant
something
artery is the one
live.
which is more easily reproducible. And you can take the measurements. Peak systolic velocity is one thing in which we are again interested in, apart from the PIRI values.
This is the peak systolic velocity, the maximum flow in the middle cerebral artery. This is important to understand because when there is fetal anemia, for any reason, अगर बच्चे के अंदर का खून पतला है, RBCs कम है blood vessel के अंदर, तो जब भी हार्ट कॉन्ट्रैक्ट करेगा तो वो RBCs बड़ी तेजी से भागेंगी और ये पीक सिस्टोलिक वेलोसिटी जो है ये बहुत ऊंची हो जाएंगी. The graph would be like this. So whenever there is fetal anemia, this graph would be like this. High peaks would be seen. So this change one has to understand, and this is the importance of the peak systolic velocity. For peak systolic velocity, it is very important to have good angle correction at the level of the measurement.
Now, when we have to look for Dopplers for middle cerebral artery, we try to first focus at the head. And then this is I'm going towards the vertex, and now here I'm going towards the base of the skull. Then I put my color on, and I try to look for the circle of Willis. So this is the circle of Willis. This is one cerebral artery, middle cerebral artery, and this is the second middle cerebral artery. So I'll try to focus one of them, and at the start where the middle cerebral artery takes the exit from the.
Try to do it in the first 2 millimeters of the start.
Yes, that is the point where you should insinuate. This is the graph of the middle cerebral artery. You will see the good big peaks there. And we take the measurements. I'm taking the auto measurement. And this is a very good, simple tool where we see this is the peak systolic velocity. This is the SD ratio 4.75, and this is the PI values, which is 1.5. This is the value in which I am interested in. Okay, and if required, if in a patient where fetal anemia is suspected, and I have to look for the exact peak systolic velocity, in those patients, I should
correct the angle.
Change the angle exactly. I hope you
This
can
is
appreciate
the vessel,
place,
and my angle was earlier
where
this.
I
Now I've changed the angle.
Now I'm changing the angle again.
It is a very easy way. Just a rotation at one button.
1.6, and now I'm corrected the angle, and now the peak systolic velocity is around 630. This is the correct peak systolic velocity. This is the way how you correct the angles.
Okay. So in middle cerebral artery, what happens is that normally it is, since it's a high resistance flow, you will get big peak flows. But for any reason, if the baby is turning hypoxic, then the mechanism is such that they would want to save the baby. At least the brain of the baby should be saved properly. So that portion would be given maximum oxygen supply. The heart, the adrenals, and the brain, these three organs are the ones which would be given maximum amount of blood. So heart, when the heart is given more amount of blood, the coronary arteries would open up, they would be wider. Normally we cannot appreciate the coronary arteries, but in the hypoxic baby you can. And in middle cerebral artery, normally the flows are this big peak and very less diastolic flow. But in a hypoxic baby, the baby is being pushed more and more blood towards the brain. So the diastolic blood would increase further. This is more and more blood in the diastole, and you will get lesser PI values in middle cerebral artery as it advances. Then can you mute the others who are speaking? Okay. And then as the the further hypoxia would increase, the blood flows would further increase in the brain. the middle cerebral artery would give more and more diastolic flow here. And this is indicative of a worsening condition of the fetus. Now, after this stage, a stage comes when the diastolic flow would further decrease. Rather than increasing, it would decrease. That is a terminal stage, because this much brain edema has developed that the diastolic flow, instead of increasing, has now come down. Now this baby is actually going to die, and that is the time. You should not let that happen. If that stage has come, then you should understand that the baby, even if you will salvage the baby, probably the baby would be with some neurodevelopmental issues later on, and you should try not to reach to that stage. Okay. Lastly, the ductus venosus.
Now I have to take Dopplers for the ductus venosus. For that, I'm taking the mid sagittal of the baby.
You have to identify the color, Elise. This is the place. This is the good diastolic flow. This is the systolic flow. This is the diastolic flow.
This time, you could appreciate the ductus venosus, I guess. Again, this is the flow of the ductus venosus. This is a good flow of ductus venosus.
This is a lot of atrial flow there. This A wave is positive.
Systole and diastole, and so much flow is there in the atrial contraction also. So there is a good.
As a baby would worsen, this you can see that atrial flow is from here, it has decreased to this much, to absent atrial flow, to reversal of the atrial flow, A wave, and this is the reversed A wave, and this is imminent death of the baby. Aortic isthmus is a new thing. Again, in aortic isthmus, what happens is the blood which is being pushed like this, it should be normally like this, but when the baby is hypoxic, at the time of diastole, the blood is, rather than going into the systemic circulation, it goes back to the cerebral circulation, and the return wave is looked upon like this. So this is the aortic isthmus graph. Now coming on to how to go about with the management. With this baseline knowledge of the Dopplers, we'll understand how to go about with managing FGR babies. Well, these two kids are my cousins, young boys, and they're 2 years old right now. And thanks to the technology of this Doppler, that we could salvage these babies. So they were, as we know, that twins is a high risk for SGS. And these babies were, this fellow was 1700 when he was delivered. So 1700 grams, and this fellow was 2 kgs when it was born. And we have been doing every bi-weekly Dopplers on these babies. And when we start finding the MCA changes in this one, that was the point when we started, when we planned that now elective section has to be done. So the deciding factor at 36 weeks in this baby was the worsening flows, rather you can say the improved blood flows in the MCA, and because of the improved blood flow, it was indicating a hypoxic status, and the PI values were gradually falling in this baby. So that is why we decided, and it was already 36 weeks by that time. So we did a preterm delivery in this patient. My learned previous speakers have already told that we define FGR by failure to achieve. There were multiple definitions, 3 centile, 10 centile, all those things. But then ultimately, every baby is different, and ultimately it is the failure to achieve its growth potential which is the final answer. And the latest evidence says that if you have to label a baby to be small for its gestational age, it could be constitutionally small, or if it could be FGR, then it is the baby who have less than 10th centile of their abdominal circumference or the expected fetal weight. And nowadays, Dopplers are mandatory for its diagnosis. I'll just explain how, and the management. Before moving ahead with this Doppler thing, there is another very, very important step, and that is the dating of the pregnancy. As we all know that it is a commonest problem when there is a discrepancy. The commonest problem is that there could be wrong dates by the patients. So any patient who comes to your OPD for the first time, the first thing is that we have to assign correct date to this patient. Now, when we assign a date to a patient, we keep seeing this in our OPDs that patient says, इस वाले अल्ट्रासाउंड के हिसाब से मुझे बताया गया था कि मेरी डिलीवरी जो है वो 2 जून को होगी, और इसमें बताया गया है कि अब मेरी 23 जून को डिलीवरी होगी, और इसमें बताया गया कि मेरी 15 जून की होगी डिलीवरी. So they keep changing their dates according to those ultrasound reports. But we have to understand that those ultrasound reports are not the reports which are assigning the dates to the patient. The date is assigned by us, and that is best if we know the date of ovulation of that patient, because if we know the date of ovulation of the patient, then it is 14 days prior to that. And if we do not know that ovulation date, and the patient is having pretty much regular cycles, then according to the LMP, we date the patient. And if that patient is not having usually a normal menstrual cycle, then we take the whatever first scan is available for that patient. If that scan is at 7 weeks, if that scan is at 10 weeks, if that scan is at 12 weeks or 20 weeks, whatever is his first scan, now the dictum says that use that first scan to date the patient. And when you do that, then that will give you the final answer, and then stick to it. That is very important. Stick to that date and calculate. Many times a patient would come to you at her end, say 35 weeks, around 35 weeks she comes to you, and then the difference per abdomen examination or something else is giving a difference. And at that time, try to take the earliest ultrasound. If she is having a bunch of 10 ultrasounds with her, take the first ultrasound and believe it, because that CRL is going to give you the best result. So the first CRL dating, keep that as a 50th centile, and then you should observe how the baby is growing on the growth chart. So that I'm just giving an example. If there is a 35-weeker patient and she's giving you wrong dates, per abdomen examination wise, she's corresponding to 28 weeks. According to her dates, she's 35 weeks. So look for her ultrasound. When she is giving you the ultrasound, that ultrasound is telling you that why the discrepancy is there. So now you have to reassign her dates, and according to her ultrasound, you will have to reassign. And then, because of 8 weeks discrepancy is a huge difference, but actually it is not going to make any difference in your management when you see and assign a proper dates to the patient. Now, this is a very important slide, and if you require, then you can take a screenshot for this, that how standard dating is done. In a less than 10 weeks patient, we have to assign date according to the CRL. First of all, believe the patient's LMP and calculate according to her LMP. Then you take her ultrasound, and on first ultrasound, if it is done at less than 10 weeks and the CRL says that her, say supposing her LMP says that her period gestation is 7 weeks, and her CRL says that it is 7 weeks and 3 days. So then you accept 7 weeks as the date. Whenever there is a discrepancy of more than 5 days, and then at that time, we do not have to believe her LMP. At that time, we have to take the ultrasound dating as the correct date. Now, how much do you have to believe the ultrasound dating? There is a rule of 8. Rule of 8 says that there is 8% variability at a given point of date when that calculation of period of gestation is done according to the days. Now, let me give an example. Say at 10 weeks, the patient has come, and at 10 weeks, her days are 70 days, and 8% of 70 days are around 5 days. So 5 days discrepancy is allowed. But if it goes beyond that, say instead of 70 days, it has become now 80 days, the 6 days discrepancy would be allowed. So that 8% variability has to be accepted. And if it is difference between LMP and ultrasound is more than that 8%, then ultrasound reports are to be given the weightage. If the period of gestation is between 11 to 14 weeks, again, CRL is the answer. Beyond 14 weeks, CRL is not taken. Traditionally, we have been taking BPD. Now BPD is again out of it. Then came the multiple parameters. Still, most of us get the reports according to the BPD, the humerus length, the femur length, the AC, the amalgam of all those things. And then finally, the dating is given. That is the standard trend. But when you are actually assigning the date, please take head circumference as the answer. Whatever your head circumference is telling you between 14 to 20 weeks, take that as an answer. There are exceptions to this sometimes when there are anomalies or you're finding a breech baby or a dolichocephalic baby. In those situations, you might have to look at the multiple parameters, but there is another dimension, that is transcerebral diameter, which is again a very standard and a fixed thing according to the, it doesn't change with IUGRs and FGR babies. So this is also one important parameter. If we are doing it later than up till 26 weeks, a head circumference is the most important. Later on in the third trimester, you have to take both of them in consideration. And you can see that how much difference can occur later on in third trimester. The discrepancy of 21 days, up till 21 days is still acceptable. So just remember this rule of 8 and how to date the pregnancy. Now, I would want all of you to understand that we have to, in modern era, we have to understand the importance of the calculators. If your patients are coming to you with an app and giving you calculations and you don't know them, then you are going to cut a sorry figure. So I would request every one of you right now to pick up your phones in your mobile, pick it up and search on your Safari or on your Google, search for FMF IUGR calculator. This, I've already given a screenshot for that. FMF IUGR calculator. Please, everyone, just type it once. I'm making you do this because I don't want this to be another lecture which you have already heard so many times, and then you forget to actually use it in practice. Please type it once in your mobiles. And then there are 4 options which are coming. In this 4 option, every one of them is of use. Try to use them one by one. All these 4 of them are very, very important. Make sure that you are using it in your daily practice. Now you open this fetal Doppler one. Okay, we'll use this a little while after another 1 or 2 slides. We'll just practice on this fetal Doppler one once we are considering the Doppler estimations. Even ask your sonologist. Why I'm insisting on this is because nowadays we are not only talking about PI values, the SD ratios, we are talking in terms of centiles. Remember, we have to talk in terms of centiles. And these calculators are actually giving you centiles. My ultrasound machine, it's an E6 machine, but still it doesn't give me the centiles. It gives me centile of the head circumference, the abdominal circumference, but it doesn't give me the centile of my MCA. It doesn't give me the centile of my uterine arteries. So for that, you have to use these calculators because that is very important for the management of IUGR. Please start using it. The abdominal and weight estimations, all this fetal growth calculator, this will give you the percentile according to the abdominal circumference, the weight. Weight is usually estimated with 3 of them: the humerus, the head circumference, the abdominal circumference, and the femur length. These are the 3 standard things which are used for weight estimations. Earliest scans are the best scans, which we have already talked about. And now I'm demonstrating you one patient. This is how we actually plot the graphs of the patient. The second important step after the dating, the second important practice which you should do to diagnose a baby who's likely to develop FGR or a baby whom you suspect has already developed FGR take out all her old reports and plot their graph on the growth charts. This is a very, very easy growth chart. It is very easily available on the net. You don't have to do get one printed and get multiple copies of this and have them in your OPDs and plot those graphs on this, plot the findings on this graph. When you plot it, then you will see how the baby is going. So in this baby, the fetal weight is earlier at this level, and now again it is at around 50th percentile itself. Earlier also it was around 50th percentile. So this baby is more or less following its own curve. But whenever the baby is falling off the graph, this is a very, very important criteria, falling off the graph. The management starts here. When the baby is falling off the graph, then you have to identify that baby, and that further vigorous monitoring would be done on these babies. Dopplers are not to be done for each and every baby. Every 2-week Dopplers are being done, but these are the ones which require that. So some babies, when they are started off, they are starting at the 10th centile. And then again, they are continuing on the same 10th centile. These are not the babies which we are worried of. The ones which are falling off the graph, they are the ones in which we are worried. So what other things in these babies, what we are going to actually look for is these two. If by any chance you are just having a single finding and the baby is on the, say at the 5th centile, first finding, and the baby is at 5th centile, and it is more or less matching their period of gestation, whatever the patient says, it is matching her dates, and the baby is at 5th centile, you are worried. What next? In this situation, you have to do further evaluation, and that is in the terms of the amniotic fluid and the Dopplers. So now this is one such example. I just happened to have this patient yesterday or day before yesterday. Yeah, it's 21st June, I think. 28th June. 28th June, this patient came to me, and she's a doctor's wife. She's had previous 2 cesareans. Okay. The first cesarean was done due to severe PIH, oligohydramnios, and she lost that baby at 7.5 months. She told me that she had delivered, and after 6 days, the baby could not survive. And blood pressure too was higher. All the findings of preeclampsia were there. So in her second pregnancy, she was given low molecular weight heparin and other stuff, and well monitored. And at 8.5 months, she underwent an elective cesarean, and there was absolutely no problem in her second pregnancy. She's had a good baby. Now, this is her third pregnancy. And in this pregnancy, she had been advised the low molecular weight heparin, aspirin, and she told me, she came for the first time, day before yesterday, and she told me, "Humne kuch nahi liya hai." Doctor's wife, she has not taken anything whatsoever in this pregnancy. BP ठीक चल रहा था, सब कुछ ठीक चल रहा था, तो हमने सोचा हम कुछ नहीं लेंगे. So she was not on anything whatsoever, and she came with this finding. Now she didn't even have her old ultrasound reports. She said that ultrasounds were done and they were fine. So I believed them. And I actually, the first thing which I did was taking her blood pressure, and I didn't believe that at 35 weeks, she was pretty obese. So first thing I did was a blood pressure, and it was absolutely okay, 110, 80 or something. So I did an ultrasound, and this was the graph. Everything you can see is at a good centile. This is around pretty much 50th centile. ये BPD थोड़ा सा और ज़्यादा ही side पे है. ये भी 50th centile पे है. Abdominal circumference. ये सब कुछ जो है, सब कुछ good था. और femur length भी ठीक है. और this is another important parameter, the head circumference and abdominal circumference ratio. This was also normal. You can also see it on the graphs. But still, because of her history, I was worried. So I said that I'll do a Doppler. She's not had any Doppler in this pregnancy. So I went ahead and did a Doppler on her. Well, I don't have that picture. It's here with me. And on Dopplers, when I did, her Doppler report said that her umbilical artery was, the PI values were 0.91. Her umbilical artery values were 0.91 and her MCA values were 1.1. Now, just wait for a moment. An MCA value which is 1.1 and a uterine artery PI values which is 0.9. This tells me that the umbilical artery values are lesser than the MCA values, which is normal. 1.1 divided by 0.9 is definitely more than 1. So this looks an absolutely okay value, right? So ये okay value से मैंने उसको वापस भी भेज दिया. But I have a habit of doing the centiles in a suspicious patient. So now take out this mobile and just plot fetal Doppler पर click करना है सबने. और इस fetal Doppler पे सबने डालना है period of gestation. Okay? Period of gestation इस patient की थी 35 weeks. और uterine artery की PI values इसकी थी 0.9. और MCA की values हैं इसकी 1.1. So what it tells me is that her uterine artery PI values are 47th percentile, but her MCA PI values are 1 percentile. And her CPR ratio, ultimately the final answer is CPR ratio, and the CPR ratio centile is only 2, which is less than 5. Okay, any value of centile less than 5 is significant. Later on, we'll discuss how frequently we should monitor. So ideally in this patient, after a week, again, we should repeat her Dopplers. Although apparently on सरसरी तौर पर MCA की value umbilical की value से ज़्यादा है, तो ये value ठीक लग रही है हमें, but actually ये ठीक नहीं है. 1.1, 0.9 से ज़्यादा होने के बावजूद ये centile में 2 ही centile पे है. So this patient needs vigorous monitoring. I've told you the history of this patient. Everything is okay. And the baby also looked pretty much okay. The weight was fine. Weight was actually 2.6 kg. But फिर भी ये बच्चा एकदम ठीक नहीं है. Now let's move further. How to manage? What are 5 steps of management? First of all, you have to identify whether the bachcha is small or not. So how will you identify that? Clinically, you look at the pubosymphyseal height. If it is less than 3 centimeters, then the bachcha is small. And if you are suspicious, go ahead, do the biometry, and that will tell you what centile. These calculators are going to tell you. If your ultrasonologist is not giving you the centiles, please open this and look for what centile the baby is. If it is less than 10th centile, remember this. If it is less than 10th centile, it is a small baby. Now you have to identify whether this baby is a SGA baby or a FGR baby. SGA means just a constitutionally small baby. As just now Manju madam has told me that, you know, so many big chunk of them is actually a constitutionally small baby. It's not a disease baby. In India, we do find small babies, but still it could be a FGR baby too. So you have to identify out of the 2. How do we identify? There are further steps to that. So after identifying, we'll just enumerate what is that. And after identifying it is SG or FGR, now what is the next step? Say supposing if it is an FGR baby. Now you have to identify whether it's an early FGR or late FGR. The whole management would differ here. Early FGR versus late FGR, major difference is, and that early and late is 32 weeks is the cutoff. I still believe in my city, I would take 34 weeks as the cutoff because we don't have very good results even at 34 weeks. But, you know, maybe a bigger cities or in foreign countries where these criteria have been made, they are taking 32 weeks as the cutoff. So I would just go with 32 weeks only. And there are a few literature studies which are giving 30 weeks also as this. So, but we'll take what is standard, and on the truthful study, what was the standard, we'll just take that. And 32 weeks you have to remember. तो अगर 32 वीक से कम पर हमें FGR मिल रहा है तो हम उसको अर्ली FGR बोलेंगे, और अगर हमें 32 वीक्स के बाद FGR मिल रहा है, then we'll call it as a late FGR. Now, how the difference? What difference would it make? placing a baby or as an early FGR or late FGR. बॉटम लाइन एक चीज बस मुझे बतानी है, जो ये पूरे लेक्चर की जिस्ट है, वो ये कि जो अभी न्यू साइंस है पिछले 4-5 सालों में डेवलप हुई है, कि जो अर्ली एफजीआर बेबीज हैं वो एक स्टैंडर्ड डिटेरियोरेशन का पैटर्न फॉलो करते हैं ऑन डॉपलर्स। क्या डिटेरियोरेशन का पैटर्न फॉलो करते हैं? जनरली जो अर्ली एफजीआर बेबीज होते हैं, पहले यूट्रोप्लेसेंटल फ्लो में गड़बड़ होती है, तो फिर अम्बिलिकल आर्टरी में गड़बड़ होनी शुरू होती है, फिर उसके बाद में बच्चा जो है धीरे धीरे डिटेरियोरेट होता है, तो फिर उसके बाद में उसके मिडिल सेरेब्रल आर्टरी में चेंजेस आने शुरू होते हैं, उसके ब्रेन को ऑक्सीजन सप्लाई बेटर होती है, फिर आफ्टर दैट दी लेटर ऑन the changes would come at the level of the aortic isthmus and lastly at the level of the ductus venosus. So that there is a gradual change and ductus venosus वाली terminal changes आ जाते हैं। जब A wave का reversal आना शुरू हो जाता है तो वो बेबी में अब imminent death का साइन आ जाता है। तो एक पैटर्न है which starts from the umbilical artery to the middle cerebral artery to the aortic and to the ductus venosus. That pattern is being followed. Now this early FGR babies usually carry a worse prognosis because of the major risk of prematurity along with the complications of being a teeny weeny baby. But there is one good part to that FGR is that ये बेबी क्योंकि शुरू से ही उनको कम सप्लाई जा रही है, तो ये बच्चे जो हैं एक तपस्वी का जीवन बिता रहे हैं, उनको कम खाने की आदत है। तो जिस बच्चे को कम खाने की आदत है उसको थोड़ा कम खाना मिलने में भी वो काम चलाता रहता है। Now whereas there is a late FGR baby जिसको कम खाना खाने की आदत नहीं, वो खाते पीते घर का बच्चा है, वो खाते पीते घर का बच्चा जब सडनली उसको कम सप्लाई होनी शुरू होती है, they are the ones who land up into more problems, and these are the ones which are difficult to identify, and these are the ones who have worst prognosis, and these are the ones which are you have chances to lose more often. These are the ones which you have missed. These are the ones which are unknown stillbirths. पता नहीं एकदम से IUD हो गई, पता नहीं क्या हुआ. These are the ones which you have to identify. और इन बच्चों में typical pattern of umbilical artery to MCA to ductus venosus नहीं follow होता. These babies, the late FGRs, are the babies in which suddenly the middle cerebral artery changes would come and the baby would succumb. आपको अम्बिलिकल आर्टरी में चेंजेस करीब 25% बच्चे ऐसे मिलेंगे जिनमें कि अम्बिलिकल आर्टरी में चेंजेस आए ही नहीं और मिडिल सेरेब्रल आर्टरी में बहुत सारे चेंजेस आ गए. So you have to catch those babies. Many times when I actually started doing Dopplers 10-15 years back, अम्बिलिकल आर्टरी पे डॉपलर करना इतना आसान लगता था कि I used to say कि, और जब भी करते थे तो अम्बिलिकल आर्टरी में अगर चेंज है तभी डॉपलर में तभी MCA में चेंज मिलता था. ऐसा बड़ा मुझे तो याद नहीं होता था शुरू में कि कभी ऐसा हुआ हो कि मुझे अम्बिलिकल आर्टरी में चेंज ना मिला हो और MCA में चेंज मिल गया हो. तो मुझे लगता था कि खाली अम्बिलिकल आर्टरी का ही करते रहो, जिसमें अम्बिलिकल आर्टरी में गड़बड़ होगी उसमें हम MCA पे जाएंगे, अदरवाइज हमें जरूरत क्या है MCA के रूटीनली करने की. जल्दी जल्दी काम करना, ओपीडी में भीड़ ज्यादा है तो फटाफट अम्बिलिकल का करो और पेशेंट भेज दो. बट नो, now if you have to identify a chunk of patients which can have problems, then you have to do routine MCAs. Also, ideally you should be doing routine uterine arteries too, but uterine arteries हर stage पर उतनी important नहीं, early stage पे ज्यादा important है, but कुछ लोगों के पैरामीटर्स में अभी भी स्टैंडर्ड जो डायग्नोसिस है उसमें along with umbilical artery and MCA यूट्राइन आर्टरी की PI वैल्यूज को भी पूरी इंपॉर्टेंस दी गई है. अभी मैं आगे स्लाइड्स में दिखाऊंगी. But what I want you to understand is I've just given you an example of my yesterday patient. बहुत दिनों बाद आई, बट मुझे लगा कि शायद इस लेक्चर के लिए ये पेशेंट आई थी मेरे पास में कि इसका सब कुछ बिल्कुल ठीक था, बस हिस्ट्री खराब थी और इसका MCA मुझे खराब मिला, जबकि मुझे अम्बिलिकल आर्टरी में कोई प्रॉब्लम नहीं मिल रही. So we have to identify these patients and we have to follow basically the protocol of follow-up is just what I'm going to share next. And early versus late के बाद में parameters which are to be followed up and stage based management protocol, इसमें कुछ बहुत खास बात नहीं है. Ultimately IUGR में, as Divya has said, nothing must can be done. कोई एस्पिरिन, लो मॉलिक्यूलर वेट हिप्रिन और कोई ट्रीटमेंट और अमाइनो एसिड और आर्जिनिन और सब ड्रामा ही है, कोई बेड रेस्ट, किसी चीज का कोई रोल नहीं है. अल्टीमेटली यू हैव टू मेक अ डायग्नोसिस एंड यू हैव टू रीच अ गुड टाइम, कब डिलीवर कराना है पेशेंट को. So that time of delivery is to be decided, and how frequently you have to monitor. जितना खराब बच्चा है उसको उतनी ज्यादा frequently monitor करना है. सारा प्रोटोकॉल उसी के ऊपर ही है. उसको मुझे somehow ऐसा लगता है कि हम क्लिनिशियंस के पास में जो एक गट फीलिंग है कि इसको 2 दिन बाद बुला लें कि 3 दिन बुला लें, वो कोई बुरी गट फीलिंग नहीं है. प्रोटोकॉल अगर कह रहा है कि पेशेंट को 1 हफ्ते बाद बुलाओ, बट आपको लग रहा है कि 3 दिन बाद बुला लो, there is no harm. We do not want to lose that baby. So the more important thing is to identify which baby is at risk. That is what you have to develop. So you have to individualize every baby, and then you have to decide that whether you have to deliver the baby early, but then there is a risk of prematurity, or you want to deliver that baby later on, but then there is a risk of IUD, that baby is having gross IUGR. So now you have to find a balance, and this game, ये वाला झूला जो है हम सारे gynecologist continuously खेलते रहते हैं, और शायद आखिरी दिन तक खेलते ही रहेंगे.
Hello, Anupma. Sorry to interrupt.
हाँ जी मैम.
How much is left now?
Ma'am, it's मैं देख के बताऊं. I think another 10 slides.
Please compile. Huh?
Okay, ma'am.
Because
Okay.
time is getting short. Okay.
That's fine. Ma'am.
Okay.
Okay. So then etiology, you can try to identify what is the etiology in very early FGRs, and in those you can find sometime causes at the level of the infection or chromosomal and chromosomal abnormalities or aneuploidies, but most of them would be the placental cause. And again, in placental cause, there is not much that you can do. You have to just identify and find a good time. What all problems occurs, it has already been explained. If the blood flow is bad in the gut, then necrotizing enterocolitis occurs. When there is decreased flow to the lungs, the more risk of RDS is there. Because of the decreased flow to liver, the bacha is chota, the teeny weeny baby is there, liker कम हो जाता है, जब किडनी में blood flow कम हो जाता है. इन 3 जगहों पे blood ज्यादा होता है, brain में, coronaries में और adrenals में, because we have to actually give good blood to these areas to let the baby fight for its own existence. So usually, at what time should we do the Dopplers? Normally, we should not be doing in absolutely okay baby. There is no need to do Doppler at very early stage. And if there is a uterine artery problem, which we are routinely doing at 20 weeks or at your anomaly scan time, which we are usually doing the uterine artery, we are also doing it at the level of the NT-NB scans. And at that time, if the uterine arteries are abnormal, then you call that patient at 28 weeks to get the Doppler studies done. Otherwise, you can call this patient later on. And what is a good balance? If we have to identify those late FGRs, ideally we have to do the Dopplers later on. But sometimes we can miss on. So the balance which has been finally answered is that we should do the ultrasounds at the level of, at this time, the 34, please mute whosoever else is speaking. 34 to 35 weeks is the time when you should do the ultrasounds, the Dopplers. And if there is any problem, definitely you have to do it early. There is no question to it. And whenever you're doing Dopplers, it should not be only umbilical, it has to be MC. So this late versus early FGRs, this is what is the latest in IUGR. And this is what we have to understand, that when do we call the baby is FGR? When it is less than 10th centile. Okay. Now, along with less than 10th centile, if there is uterine artery PI, which is more than 95th centile. Now, this is what I was talking about, that why looking at centiles is important. This is the latest and the standard guideline, how you should diagnose your patient to be having an FGR. So this standard says that the criteria itself, that is why we say that Dopplers is must now. The criteria says that the uterine artery PI is more than 95th centile, or the umbilical artery PI is more than 95th centile, or your baby is less than 3rd centile. Along with 10th centile, there are Doppler problems, or if there is no Doppler problem, but the baby is so small, less than 3rd centile, again, it's an early FGR, or you are not finding anything else, but the baby is having absent flows, which should not be there. Again, this baby is a early FGR. Which babies are the late FGR babies, which are more than 32 weeks. And along with this less than 10th centile, there is either a crossing over of the centile on the growth chart, or the CPR is less than 5th centile. This was my patient, yesterday's patient. This is where she lands, less than 5th centile. She was on 2nd centile. So she's not having any growth lag. She's not having anything like this, but she is definitely having a CPR less than 5th centile, or the baby is so small, which is less than 3. So these are the babies you have to identify. And these babies need vigorous monitoring. What all is to be done? The comparison between late and early is this, that the spectrum of Doppler alterations is a standard one, whereas in this, the cerebral flow redistribution occurs earlier, and there is reduced MCA flows. That is why there is reversed cerebroplacental ratios, and that is why these babies are more difficult to identify. Although the umbilical arteries are the mainstay in the diagnosis, but in these babies, MCA are the more important ones. In preterm babies, even if MCAs are bad, now take my words here, even if MCAs are bad, we are not going to deliver the baby. We will wait and wait and wait till the baby's ductus venosus flows are still showing the forward flow. We'll probably wait, because in this baby, if we are going to deliver them early, we are taking out a very, very premature baby. And so in these babies, ductus venosus flows are the ones which are going to be the deciding factors that what is the good time to deliver this baby. Whereas in FGR, ultimately it is the failing MCAs which are important and which tells us that we have to take the decision to deliver this baby. Here, the MCA has limited value and we are mainly watching for ductus venosus, and the absence or reversal of A wave is in the ductus venosus is the indicator of delivery. What is the difference between these two? The management is a problem in this baby because it's a very teeny weeny baby, and in this one, the problem is diagnosis. In this, the placental disease is more severe. इसमें placental disease mild सा ही होता है. Pre-eclampsia के chances इनमें ज़्यादा हैं. इसमें lower association of pre-eclampsia है. इसमें hypoxia definitely ज़्यादा है. इसमें plus minus है. But इनका टॉलरेंस पुअर है, इनका टॉलरेंस बेटर है. ये बच्चे बेचारे फिर भी बर्दाश्त करते जाते हैं, तपस्वी का जीवन व्यतीत करते हैं. And then fetus is naturally immature in this one. This one is a good one, and this morbidity is higher because of the prematurity factor. This was again an example of a patient. I'll just skip it because this is a case scenario and I was going to ask questions. I'll just fast I'll do it. A normal patient, primary, everything okay. Pape values are just borderline. And this patient has come for a second scan and we are finding on first scan, everything is okay. Now this patient has come for a second scan and there is a lag of 3 weeks. Now, whether it's a SGA baby or it's not an SGA baby, it's an SGA baby because it's a big lag there. Now, is there any indication for Doppler? It's a 19 weeks baby. Dopplers are the umbilical and MCA would not give us much answers. So we will do a Doppler, but that Doppler will be of uterine artery. And we will try, this is such a small baby that we are not really suspecting a placental problem over there. And in this patient, we have to look for other factors like aneuploidy markers, the infection screen, the fetal anatomy, and then again Dopplers later on. After 28 weeks, if the baby survives, after 28 weeks, we have to follow it. Nowadays, they say 26 weeks, they have to follow this baby, and according to the protocol, which we'll just enumerate. Now, how many types of stages of FGR are there? These are these 4 stages. And this is the Barcelona management algorithm, and which says that the 4 stages of baby the deterioration are these. Mild one is when there is the CPR ratio is less than 5th centile. These are more than 95th centile. The baby's weight is less than 3rd centile. This baby is to be monitored weekly. If the stage is of compensated hypoxia and which is apparent by this, then it is to be monitored more frequently, and that is bi-weekly. these are the stages which are there. If you want to take a screenshot, you can. So this severe placental insufficiency, the more frequent monitoring is required. If there is suspicion of fetal acidosis now, along with the reversal of the umbilical flows, there is also ductus venosus flows, PI values are more than 95th percentile, then you have to follow it every day. And if there is further reversal of the ductus venosus flows going towards this, then it's an imminent death and 12 hourly, or probably you will have to deliver the baby. I would actually never let my baby go beyond this stage. This is the maximum which we can extend any baby. We all know that fetal heart decelerations are a very terminal events, and CTG changes are not the ones which are to be relied for monitoring. It is the Doppler which is to be relied for monitoring. This is the sequence of event which occurs. And incremental placental impedance would change first the uterine artery flows, then the umbilical, then the middle cerebral artery, and gradually the ductus venosus. This is the standard. Few ISO guidelines and few other guidelines actually incorporate computerized CTG in their algorithms. We are not doing computerized CTG. Maybe a few of you are doing it. Then that is to be incorporated in the standard protocol. This is the protocol for the early FGRs. You can take a screenshot if you want to. Basically, it is just to tell you that at what stage, how frequently you have to monitor. इसमें हफ्ते बच्चा monitor करना है, इसमें हफ्ते में 2 बार करना है, इसमें daily बच्चा monitor करना है, 1 or 2 days पे करना है, और इसमें daily करना है, और probably this is the time when you're actually going to deliver. According to all this, you have to decide if there is placental insufficiency is not too much, you can go for labor induction too. But if the period of gestation is less than 34 weeks, I would never go for labor induction. I would definitely go for a cesarean section. And later on, the earlier than that, definitely we have to go for a cesarean section. This was the Barcelona algorithm again. This is again the same algorithm in a different pattern. Just 2 slides are left now. And the neuroprotection, just a word about that. Whenever you are going for delivery in these babies, try to give some neuroprotection because, you know, chances of intraventricular hemorrhage is definitely high. So that has to be taken care. And these 2 are most important. Betamethasone is for the respiratory component, 12 milligram 2 doses apart, or 2 doses 24 hours apart, or 6 milligrams 12 hours apart. 4 doses can be given. If we have given, I usually practice that if we have given betamethasone more than 2 weeks back, then we again repeat a rescue dose before delivery. And if the initial dose has not been given, then definitely you will have to give on the first interaction with the baby. Any baby which you think that might need a delivery soon enough or will need a premature delivery has to be given the steroid cover. Another thing is max self coverage, and that is 4 gram bolus, and then later on 1 gram till next 24 hours till the baby is delivered. So next 24 hours, we expect that the baby is going to be delivered. Earlier practice was that we have to do early cord clamping. Now the practice has changed, and now it is saying that we have to do delayed cord clamping. Let that extra blood go to the baby. If there is any other problem, any infection or anything, you have to deal. If there is PIH, according to that. Many times your maternal reasons would change your treatment plan. You know, your timings would change if there is maternal problem, if the mother is having SLE or some renal problem, and because of that you might have to deliver the baby, which otherwise because of the Doppler flows you would have extended till 34 weeks, but because of the mother you might have to deliver that baby early. So ultimately it is a comprehensive decision which is to be taken by the clinician, but then final decision which whatever you are taking, हमारी रितु मैडम का decision जो है वही final है. And kangaroo care is the new thing that the baby should be given up to the baby, and that's about the neonatology part. Divya has covered it very well. कुछ भी चीज बहुत पक्की नहीं है. Aspirin का और low molecular weight heparin का pre-eclampsia के साथ में ज़्यादा role है. All of this is just. I just wanted to say a word about bed rest. Too much bed rest is advised. Of course, what is actually recommended is that vigorous activities are to be avoided, but total bed rest is some amount of blood circulation is rather beneficial for the patient, and she should do her normal sedentary workups. This is again one of the truthful things. Nothing important there. अलग अलग आईसीओ की गाइडलाइंस है, घूम फिर के सबने वही चीज बोल रखी है कि बच्चा कब डिलीवर कराना है. अनदर बार्सिलोना का एक और पिक्चर है ये. Finally, I would close by saying that मोटा मोटा जो चीज याद रखनी है वो ये कि अगर हमारा बच्चा 30 to 32 वीक्स के आसपास है और हमें रिवर्सल मिल रहा है तो हमें बहुत ज्यादा विजिलेंट रहना है. जिस जमाने में हम डक्टस वेनोसस की नहीं कर सकते थे, इफ देयर इज नो फैसिलिटी अवेलेबल, यू आर एट अ रिमोट प्लेस and you cannot do a ductus venosus flow, in that situation just umbilical artery कोई भी कर सकता है. umbilical artery करने में अगर हमको रिवर्सल मिल रहा है और बच्चा इतना छोटा है तब भी आपने डिलीवर कराना है. बड़ा है तो डिलीवर कराना ही कराना है, लेकिन इतना छोटा है तब भी आपने डिलीवर कराना है. अगर एब्सेंट फ्लोज मिल रहे हैं तो हम थोड़ा सा एक्सटेंड कर सकते हैं, बट 34 वीक्स के बियॉन्ड देयर इज नो पॉइंट गोइंग. इवन 34 वीक्स तक आपने ले लिया तो बच्चा और ये एब्सेंट फ्लोज के साथ में देयर इज नो पॉइंट एक्सटेंडिंग फर्दर. एंड इफ देयर इज ओनली हाई पीआई वैल्यूज, अभी एब्सेंट नहीं हुआ है, सिर्फ अभी हाई हुआ है पीआई वैल्यूज, तो यू कैन टेक अ चांस एंड गो अप टू 36 वीक्स. एंड इफ अलाउड, आपको एमसीएस अलाउ कर रहे हैं तो आप 38 वीक्स पर भी जा सकते हैं. So finally, my take home message is that it is very, very important to do correct dating. Start using growth charts. SGAs, any SGA which is less than 10 centile, you have to be vigilant. Dopplers you cannot बच नहीं सकते हैं अब हम इस जमाने में. Anyone I told who's less than 40 years यहाँ पर बैठा है, हमारी बात सुन रहा है, उसको डॉपलर सीखने ही सीखने हैं. And early onset वालों के लिए venous Dopplers. This is one thing which has been incorporated. These are those छोटा babies which I started off with. 1700 वाले बच्चे. And thank you. I love to teach here. And मेरा सबसे बड़ा वाला thank you अभी जाता है रितु के लिए, because actually she was the one who pushed me. मुझे आज तक कभी इतने lectures मैंने दिए होंगे, कभी किसी ने ये नहीं बोला कि तुम ये भी कवर करना, तुम ये भी कवर करना, तुम ये भी चीज बताना, तुम ऐसे प्रेजेंटेशन करना, तुम ये वाली वर्कशॉप सिनेरियो रखना, उसमें क्वेश्चन आंसर सेशन रखना, उसमें ये भी करना, उसमें वो भी करना. मैंने कहा मुझे टाइम बहुत सारा देना, इतने सारी चीजें बोल रही है तो. So this is how we conduct the workshops at our place. This was the Doppler workshop which we were conducting. Thank you so much, Ritu. Thank you, everybody over there.
Thank you, Dr. Nupma. It was a brilliant presentation. Now I invite Dr. Madhu Mittal Madam to please conclude the session.
Good evening, everyone. Am I audible?
Yeah, Didi, please.
Okay. So I would like to thank AOGS and VOGS for having me today as part of this webinar. And Dr. Anupma, that was a fantastic lecture. We can see how enthusiastic you are about teaching. And I really appreciate you.
Thank you for participating in my passion, actually.
So just to summarize, to a couple of things, that our whole definition of FGR is based on the percentile growth. And we can talk about percentile growth only if we have a reference dating, that the dating started from here, and therefore we can now say that the growth is not appropriate for the age. So that dating part is very important. Second thing is that all the gynecologists, obstetricians, they may not know how to do the Doppler, but definitely they should know how to interpret the Doppler and understand what those readings mean. And when to, it does not mean that every patient who has a high uterine artery Doppler in the third trimester, say at 31 weeks, that is not the trigger for delivery. And therefore one should not get alarmed at a high uterine artery Doppler. So one has to know what is the balance, how to interpret it. And just to make things simpler as far as the management is concerned, Dr. Anupma referred to the Barcelona algorithm. So it's quite confusing if you go into the details of it, but as long as there is positive diastolic flow in the umbilical artery at any stage of gestation in a growth retarded fetus, you know that you are still in the stage 1 of Barcelona, and therefore no intervention has to be done as far as delivering the baby is concerned. You can try to take the pregnancy up till 37 weeks of gestation, provided that you do weekly monitoring of the Doppler and 2 weekly monitoring of the fetal biometry for growth. So if as long as the uterine artery flow is, umbilical artery flow is positive, you know you are in stage 1 and you don't have to worry. You just try to do the Doppler weekly to see where the umbilical artery is going, right? So, and of course, if the umbilical artery flow is absent, then you know that you cannot go up till 37 weeks. You have to deliver at around 34 weeks or before, depending on the other parameters. There is just one more thing I would like to mention. As Dr. Anupma had, she said she had a patient yesterday. The weight was normal, but the cerebroplacental ratio was less than the 5th percentile. So, and she has a bad obstetric history as far as the FGR and preeclampsia is concerned. So now the latest thinking is that babies whose percentile weight is in around the 80th percentile, they are going to have good neonatal outcomes. But if the percentile is less than the 50th percentile for that gestation, and these babies may be technically, as per the definition, appropriate for age. But if their cerebroplacental ratio is abnormal, then they are also, they may be potentially growth retarded babies and not actually having reached their full growth potential. Although as per the general charts, they are still within the 50th percentile growth. So we have to be aware that you may have a apparently good weight baby, but maybe the baby was destined to be even a higher birth weight. And if the CPR is low, then we should potentially be on alert that this may be, baby may land into problems, and just monitor that baby a little bit more carefully. So I think that was a very brilliant webinar, and I mean, that's, Dr. Anupma has covered it so much, there's not really anything left for me to say. So thank you very much.
Thank you, Didi. Thank you, Mati Madam, for your valuable inputs.
Ritu, you are a good motivator to me, and thank you so much.
Yeah, and thank you, Anupma, for this brilliant presentation. And I must say that many of our members will now get motivated to do ultrasound.
We should start looking at umbilicals first of all. I mean, umbilical में कुछ भी बड़ी चीज नहीं, अगर आपकी मशीन में है तो आपको देखना चाहिए.
पर मेरा तो husband is radiologist.
Okay, हो गया.
तो भी उसको खड़ा करके
You can always be better than him.
चलो देखते हैं भैया चैट बॉक्स में क्या है. Only one question. मेरे ख्याल से सब लोगों ने you all made it so clear to everyone, na? So no questions are there except for one. What is the management of oligohydramnios in 16 weeks primary gravida, aged 26 years old? Okay, someone wants to know. Dr. Anju Mishra wants to know. The patient is a primary gravida 26-year-old patient presenting with oligohydramnios at 16 weeks.
There is not much that we can
go with that
baby, because it's a 16-weeker. In the management of this baby, there is no role of Dopplers. We have to basically look for the cause, because most probably it might be having an infection or any anomaly.
Not anomalies.
Not
anomalies.
Anomalies, definitely. That is the first thing.
Right.
And if at all the baby crosses 26 weeks, it survives that time, then only we can think of saving that baby. Otherwise, we cannot salvage such a baby if it is going to persist with severe oligohydramnios. And
And when the fetal biometry is normal, say, and umbilical Doppler is abnormal, does that mean that baby is going to develop late onset IUGR, or should you look for some
early
other?
onset? It is early onset IUGR, because
so the biometry is normal. Say the biometry is normal, but the umbilical Doppler is abnormal.
This baby has to be followed.
How should you go about for this baby?
Very soon, this baby will eventually develop an early IUGR, because
shouldn't we take? Shouldn't we review this patient again to look for some other fallacies in doing umbilical Doppler?
we have to follow this patient every 2 weeks. And on every 2 weeks, when we are following this patient, we will have to find whether the baby's biometry is still persisting well or not. अगर उसके डॉपलर में चेंजेस नहीं मिल रहे हैं हमें या सेम मिल रहे हैं, तो वी कैन कंटिन्यू विद द प्रेगनेंसी, बिकॉज बहुत सारे बच्चे ऐसे होते हैं जो कम सप्लाई के साथ में भी अच्छा से काम चला लेते हैं.
जी, पर ऐसा होता है कि अम्बिलिकल डॉपलर में चेंजेस मिले एंड फीटल ग्रोथ इज एब्सोल्युटली नॉर्मल.
Yes, yes, it is possible.
And in such patients, yeah, in such a patient, first of all, I would like to go back and see the first scan done and confirm that you are actually looking at a correctly dated pregnancy and not an IUGR pregnancy, which is falsely presenting as appropriate for growth.
I think that insufficiency is there in Dopplers. That is what she's saying.
Umbilical Doppler is showing abnormality.
Yeah, so there may be two things. One, obviously, any abnormal Doppler has to be actually technically repeated within 12 hours to confirm that it is truly abnormal. And number two, if the baby is showing breathing movements, at that time also you can get abnormal, any Doppler may be abnormal because the breathing movement changes the intrathoracic pressure and therefore the cardiac output, and then the whole scenario changes. So you have to ensure that you do it when the baby is quiet and not breathing. So you still would like to repeat the umbilical artery Doppler after, say, maybe 24 hours to confirm that it was truly increased.
Because they say that there should be at least 40% of villus dysfunction for the biometry to get deranged. And this umbilical Doppler becomes abnormal when 60% of the villus dysfunction is there.
Yeah. So I would like to repeat the umbilical Doppler to confirm whether it is truly abnormal and not just base that on a single reading.
We have to understand that even if the uteroplacental insufficiency is being shown by the Dopplers, still if the baby is managing it, then we have to continue the pregnancy. Because the baby is ultimately what we are achieving. We have to just let the baby pass on with that time and reach the stage of maturity. So even if the insufficiency is there and the baby is able to bear it with it, we'll have to continue.
Sometimes it also happens that biometry is normal, uterine artery Doppler is normal, but middle cerebral artery Doppler is abnormal. Then how should we go about that then?
In such a patient, you have to be very, very vigilant. Very frequent monitoring is required because these are the ones, late FGRs, which are likely to succumb, and sudden IUDs are there. Because in these patients, as that algorithm says,
should we consider the age also, the gestational age also? Should we consider that?
If in such a patient, that patient has reached 37 weeks, we'll have to deliver that patient.
Right. Okay, I think that's
Ritu, can I say something?
Yeah, sure, madam. Please go ahead.
Anju ma'am ke shabd sunne de mujhe.
Madam, please, madam.
I would like to say here that there is a sequence of events that occurs that 40% of placenta, if it is working, the baby will not be at a much of the disadvantage. So that's one thing one has to take into consideration. The other thing is that the changes that start in the umbilical artery first, and then it is the arterial system of the baby that gets deranged. And once the venous arrangement, blood flow gets deranged, then only the baby is at a higher risk. So it is how that one has to see whether it is the arterial flow which has been hampered or whether it is the venous flow. Because now we can do the venous flow. So once the venous flow is obstructed, that it means the baby is not getting the proper blood supply and the nutrition. And then one has to decide what is to be done.
Okay, madam. Thank you, madam. Okay, okay, Avi. So I think we are done with question and answers. Now I invite Dr. Kavita Agarwal, a renowned infertility expert and director consultant of Guru Kripa Jagrati Hospital, to give a vote of thanks. Dr. Kavita, are you there now? Dr. Kavita?
Yes.
Yeah, please go ahead with your vote of thanks.
Thank you, Ritu.
Shooting time, actually.
Thank you, Ritu. I deem it a great honor to propose vote of thanks to all who have helped us in making this webinar such a resounding success. First of all, I would like to propose hearty vote of thanks on behalf of AOGS, VOGS, and Rudrapur Obs and Gynae Society, to our chief guest, Professor Dr. Anuradha Khanna ma'am and Dr. Ranjana Khanna ma'am, for taking out their time and gracing today's webinar. Thank you both for your very interesting and thought-provoking address. Now, I would like to thank our chairpersons, Dr. Manju Verma ma'am, who is always ready to help us. We would like to express our profound gratitude to her for support. Dr. Anleep Agrawal ma'am, past president AOGS, she is very dear friend of mine and very close to my heart. Thank you, Anleep ma'am. Thank you, Dr. Amita. Amita, she and Dr. Divya, both are my next juniors. And जो बात इसने बोली about Divya, कि she is topper of PGME ना, PGME and all. You know, that time हम लोगों को ऐसा लग रहा था कि जैसे हम लोग किसी another world में हैं. But Amita is such a gem of a person. इसने दिव्या के बारे में तो बोला, but she was also one of the toppers. ये कोई टॉपर ही होता है जो बहुत ही हम्बल होता है, वही दूसरों की इतनी अच्छी क्वालिटीज को एक्सप्रेस कर सकता है, जो कि दिव्या कभी भी अपने सीवी में नहीं लिखती. Thanks to Dr. Madhvi Mittal ma'am for taking out her precious time and accepting our invitation. Thanks to Dr. Mamta Singh and Dr. Pushpa Pal to giving your valuable inputs. Now I would like to thank our distinguished speakers, Dr. Lalita Shukla ma'am, President AOGS, Dr. Divya Agarwal, President VOGS, and Dr. Anuradha Futela, President Rudrapur Anupama. No, Anupama.
Yes,
Sorry.
yes.
Rudrapur Obs and Gynae Society for such a detailed Doppler talk. And thanks to all of them for making excellent presentations and making this webinar interesting and meaningful. Dr. Madhvi Mittal ma'am and Dr. Anupma, your content today will be echoed in our mind for a long time to come. We are happy to express our thanks to all attendees who turned up in great numbers, as without their presence, this webinar couldn't be a great success. In the last, I would like to thank our sponsors, Team Akumentis, for organizing the webinar. They are really generous enough to trust us with their contribution, and we take it as an honor that they put in our effort. Once again, I would like to thank each and every person whose contribution made this webinar a great success. Oh, how can I forget to take name of Dr. Ritu Sinha? She is really a one-man army. Without her efforts, this webinar can't be a great success. Now I want to hand over this stage or mic to Ritu if she has any announcement to do. Thank you.
Thank you, Dr. Kavita. As it is said that happiness is meeting your old friends after a long time and feeling that nothing has changed. And I think this is the kind of feeling that I had today because Anupma, Pushpa, Amita, Divya, and you too, all my batchmates. So for me, it was like a rendezvous with friends. And that has brought back many memories. And I thank you all for being there. With this happy note, we close this session with Dr. Lalita's permission. Dr. Lalita, should we now close this?
Sure.
Thank you so much.
Bye-bye, everyone.
Namaskar, madam.
It was absolutely your show, Ritu. It was absolutely your show, and it was a good one.
It was your show. You stole the show.
Thank you for giving us
हमारा खेल तुम्हारा हमको सबको पता है कि कितनी तुमने मेहनत करी है इसके पीछे. I can vouch for that कि तुमने कितनी मेहनत करी है इसके पीछे.
यार मैंने क्या तुम लोगों ने present किया. You all presented it, made it so well, ना Divya, you and
पता है कि
I just appreciate
I
you
should
all.
share it with everyone that the brain behind this child is actually.
Thank you so much, Anupma. Thank you very
I
much.
request that if
Yeah, sure. Please go ahead, Sandeep ji. Yes, Hanji.
And this opportunity can be given to me every time.
Okay, thank you for thank you for being so generous.
Thank you so much.
Pleasure, ma'am. Pleasure.
Thank you,
Lalita ji, आपको बहुत बड़ा thank you. Pushpa dear, many thanks.
Thank you so much to the panel from Akumentis side.
Right.
Sandeep is based there. He is always there. Any kind of academic feast, we would like to partner with you.
Thank you.
Thank you.
Thank you.
Yeah. Thank you, Team Akumentis. Thank you.
Bye.
And bye.
Bye, Amita ji. Bye,
Bye,
madam.
Bye, Anupma.
Bye.
हाँ या अब बोलो अब ऑफलाइन बोलेंगे
बढ़िया, खत्म हो गया अब?